In the Southwest LHIN, we're strong advocates of exploring patient experience approaches and ensuring engagement of individuals and their families in the work that we do. And I'd say we've been on a journey over the last 8 years as a LHIN to understand how to do that well. And I think our approaches and thinking have changed over time, but most recently it's certainly something we're exploring in a lot more detail and really trying to emphasize in the work that we're doing. So I personally am looking forward to the day and learning as well along with you around the different strategies and approaches that we can use. Just from a housekeeping point of view, I'll just maybe add in a few comments. The washrooms are located to the back, towards the left. Folks have probably already found the room behind us. There's food located there, so that's always good to know. I understand there might be a TV downstairs as well. And Shelley has the Sochi app on her iPhone. So if you're looking for on-the-minute updates around Olympic activity, she's your go-to person. And we'll try to provide updates throughout the day as well. The other thing I think just to talk about with you this morning is really just a sense of what today is about. So we do have a number of objectives for the forum this morning and this afternoon. So understanding why patient and client engagement is important for each health link, learning the effective principles and methods for patient-client engagement, learning from the experiences of our health service providers and patients regarding different approaches to patient engagement, and providing an opportunity for each health link, importantly, to discuss your plans for patient and client engagement. So we hope to have a good balance today of talking with you about best practices and approaches that can be used, and allowing time for each of the health links to strategize on how you'll incorporate patient experience into your work. So just a quick overview of the agenda, and this should be in your package materials as well. We have a full day planned, again a good balance hopefully of presentation and dialogue. And so you can see from the agenda that we're going to be hearing shortly from Kathy Fuchs, and I'll introduce Kathy more formally in a moment. We have some great experts to talk to us in the sessions Through Their Eyes, Gail and Amir. And we'll also hear from Andrew McLeod this morning before our networking break. And then we hope to have some local experiences shared with you. We've done a fair bit of work in our LHIN specifically around patient experience, experience-based design rather, and have really built that into some of our projects and initiatives. And there's great work happening as well at Participation House, and so we're going to hear from Carmel Tate. So again, we've got some great examples to share with you this morning as well. And then it'll be your opportunity to break out into your health links. And I know you're sitting with your respective partners within your health links already, and have the opportunity to do some strategizing this morning before we actually have our networking lunch. And this afternoon we'll have another session Through Their Eyes, another opportunity for you to dialogue at your tables and do some do some planning around your health links and your strategies. A final networking break, and then our final Through Their Eyes session. So it's a full day. We will commit to wrap up by 3:30 and send you on your way. Hopefully you'll bundle up and stay warm. I personally am liking the fireplaces strategically placed in the room, so I think those will be a go-to place today as well. I also just want to, before I introduce Kathy, just mention the materials that you were provided. So, and I didn't bring mine with me, but on the right-hand side, I think all the resource materials are there for you, if I recall. On the left is your agenda. The bios for the speakers today are there as well, and there's a worksheet that you'll be using in your planning groups. So just to help you navigate that this morning. So again, why is patient engagement important? Without sustained patient-family participation in all aspects of policy, program development, and evaluation, the care system will fail to respond to the real needs and concerns of those it is intended to serve. And again, as I said, we are very committed in the LHIN to really using patient experience as a driver of health system change and health system improvement. It's about understanding through the eyes of the patient what their experiences are and what the opportunities are for change, and ideally engaging them in that change process. I should say that we struggle a little bit, as always, with our language in the healthcare system. So is it patient, clients, residents? My personal preference is individuals and families. But that doesn't always fit in all of the sentences. So you'll see we use the words interchangeably, but obviously invite you to use the language that makes most sense for you. I think we all know what we're talking about when we use those various words. Within our integrated health service plan, we have 3 broad goals, and they are aligned as well to the Ontario Action Plan. So improving population health and wellness, improving person experience with the health system, and improving sustainability of our health system. So again, I really just wanted to highlight that alignment and that focus on person experience as being key to the transformation journey that we're embarking on for our healthcare system. And again, we look to use multiple methods of client engagement or individual engagement in the work that we do within the LHIN. We regularly engage, and we really use the ladder of engagement to look at those different ways and objectives of engagement. So sometimes it's really just about informing and keeping people up to date with good information. Sometimes it's really about engaging them and empowering them to help with decision making. So there's that whole range of objectives when we look at how and why we're engaging, but it's certainly something that we do a fair bit within the LHIN through broad sort of engagement activities, focused committee work, etc. And within our IHSP as well, we've identified, I want to highlight quality and value as a key driver of change. And again, we have a specific objective within our IHSP to champion improvements to the care experience through experience-based design techniques. And we have called out EBD, or experience-based design, as a specific tool and methodology that we're very focused on. But I do want to just highlight that that's one tool, one approach, one methodology, and there's other approaches to patient experience as well. And so while we don't like to be too focused on a single methodology or a single tool, we certainly welcome people to draw from all sorts of methodologies, but it's one that we found is very practical and something that we've been able to learn from and incorporate in our work. So why is patient-client engagement important for HealthLinks? I should probably be asking all of you that question because I'm sure you've been talking about it and in the planning work that you're doing. Certainly we know it's been coming forward in the business cases that have already been developed in our LHIN and across the province. But we know that the main goal of HealthLinks is about coordinated patient-centered care, focusing on those complex clients and particularly seniors. And so it's very logical. If our focus is on the client, the individual, we really need to ensure that we're incorporating elements into our process that focus on that patient experiences. We really do need to include the patient and client as part of the care team in this model of care that's being advocated for the HealthLinks initiative. And as you know, your business plans require it. So it's not only part of the requirement, it's intuitively the thing that will make HealthLinks successful, I believe. And one of the 3 evaluation metrics for HealthLinks is enhancing the health system experience for patients with the greatest healthcare needs. And so while we don't always have great strategies for measurement, we need to continue to work on that. It is, again, built into the very core of the HealthLinks initiative. So what could patient engagement look like in a HealthLink? So strong involvement of patients, families, and caregivers in all stages of HealthLinks, which includes from planning through to execution and care delivery. And I think, from the examples we've seen in our LHIN and across the province, it's happening to varying degrees. So what we want to encourage is for folks to really start strong with that patient experience and engagement right at the start of the HealthLink process. Incorporating the patient, caregiver, and family perspectives into the coordinated care design process. So really, again, engaging clients to help with what the changes in processes look like, as well as then being involved in those processes when they're executed on the ground. Clearly, the patient, client, their family members need to be a key participant in their own individual care plan. And development of patient stories as a way to learn and improve through the HealthLink approach to care planning. And that's something we've really tried to, I think, increase in our LHIN, is that focus on the patient story. You'll hear from Sue McCutcheon later today, and I always enjoy Sue and the work that we do because she is always bringing forward those patient stories, and she's building them into PowerPoints, and she's building them into newsletter stories, and I've certainly grown to appreciate that. Our board appreciates that. And I know others, partners, etc., appreciate that. And it really makes it real when you can bring it down to a specific patient story and understand the impact of the work that's happening. So as always, you can go to our website for more information about the LHIN. But at this point, I'm very pleased now to introduce Kathy Fuchs. I think many people in the room probably know Kathy. Kathy is the president and CEO of the Change Foundation and has been in that role since January 2007. She brings very strong leadership skills with more than 20 years experience in health policy research. During her tenure at the Change Foundation, she's transformed the foundation from a granting agency into a respected health policy think tank focused on health integration and patient outcomes. And certainly we're enjoying the opportunity to partner with the Change Foundation in today's session, and they are one of the key provincial partners in the HealthLink initiative. And so I'll let you read more about Kathy in the bio that's in your package and turn it over to her now. So welcome, Kathy, and thanks for joining us today.
Thank you very much, Kelly, and good morning, everyone. Can you hear me okay? So it's a real pleasure to be here. We have been, as Kelly said, we have been working with all of the LHINs to try to organize sessions for HealthLinks because we so fundamentally believe in what it is you're trying to do. And as we travel around and meet with groups and individuals, I have to say that I've been struck by the amount of enthusiasm and goodwill that we're seeing, which after 25 years in healthcare, you get a little jaded. So it's very, very nice to be here with you today and to listen to what you are going to do. So in case you don't know the Change Foundation, I have to be careful assuming that people do know who we are. We've been around for almost 20 years. We were set up by the Ontario Hospital Association in 1995. We are a charitable endowed foundation. And right now, our focus really is on trying to improve the patient and family experience, particularly for people with chronic conditions as they move around the system and have often a lot of difficulty in that transition phase. We do undertake research and policy work, but we also fund on-the-ground community-based work, and we have a very large project at the moment in the Cobourg area, which some of the presentation I'm going to go through today comes from that work. We also have our own panel of citizens, patients, and family members looking after people with chronic conditions as an advisory group to the Change Foundation. And one of the members of that group, Gail Long, is with us today, and you're going to hear from her a little bit later. And that group really keeps us honest and on our toes, and it does allow us to be able to say that we do walk our own talk. So what I'm going to do today in my 20 minutes or so is just contrast sometimes how providers talk about healthcare and experience of healthcare in Ontario and how citizens talk about healthcare. That's work from our panel. A little bit about what research says. 2 slides on experience-based co-design. Kelly's touched on it already, so I have a sense you already may know what that is, but it is a methodology that we do use and our community-based project use. And then I'm going to end with a short little video of some of the people in Cobourg talking about what it's like to experience experience-based co-design, both from a patient and a provider perspective. So you think about now sitting in your chair, the graphs, the charts, the diagrams you've seen that actually try to explain the Ontario healthcare system and what that journey looks like. This is a slide that Walter Woodkiss uses. He's a researcher at the University of Toronto, heavily involved in the evaluation of HealthLinks. And this is, I think, a fairly standard, probably diagram of what you would think about in terms of the sectors of locations of care and how people have to journey through it. Sometimes it's easier, sometimes it's not. And then we went to our citizens panel and we said, close your eyes and just out loud describe something, 2 words, in terms of what you think about healthcare. And then we had somebody draw pictures. And I have to say, and I've said this to the panel, I was a tiny bit skeptical about this exercise. I wasn't exactly sure what we were going to do with it. But it's turned out to be a very, very powerful way of showing people what patients and caregivers think about. So that's the mural they came up with. It looks a little different than Walter's picture. And when you drill down into the little animations, you can actually pull out some themes. So this one talks about the Ministry of Health and the difficulty that the ministry has in trying to balance care right across the province, knowing that in some places it's quite good and in some places it's not quite up to standard. This one talks about a power imbalance that people sometimes feel as patients trying to deal with healthcare professionals in the system. This one talks about wanting patients to have a little bit more power, wanting to understand what expectations are, where authority lies, and what rights they might actually have in the system. I love this one. This is about bad communication. So that's 2 healthcare professionals using tin cans to talk to each other. This is talking about, particularly for seniors, sometimes feeling that they get labeled very quickly because of their age. and to potentially often women as well. So just reasons why sometimes people feel like they're not connecting with the healthcare system because the healthcare system perceives them in a certain way. This is about the use of health information and not really understanding who has it, how to access it, and how it travels. This is barriers to care, so if you don't speak English, perhaps your literacy is not as high, whatever it might be, people do perceive barriers to accessing healthcare or perceive that the system just doesn't really understand what their needs are. This is trying to get at the notion of randomness. So this came from an individual who had a brain injury, and so he was traveling from his home community to specialty care centers and often to Toronto, and how sometimes when he got up in the morning and he went to whatever appointment he had, it was a really good experience, and the next week the same thing could happen and it wasn't very good. So he had this feeling of, I'm getting in my car, I'm going to my appointment, and today I'm rolling the dice because I'm not sure what's, it's luck of the draw. Will it be a good day or a bad day? This one captured the notion of team and really wanting to have a team approach in terms of feeling that there's support around an individual and a family. And then these were some of the solution things that people sort of articulated very quickly. A lot of it was related to electronic information and the movement of information in a timely fashion. So kind of different images than when you look at that little sector diagram with arrows. So just an interesting contrast in terms of what matters to patients and family members as they're trying to navigate. The project that I talked about in Cobourg, it's called the PATH Project. It's a large investment for us anyway. It's a $3 million investment over 2 years to support a group of healthcare providers and patients and family members equally, shared decision making, trying to redesign local care. Now this was a community that thought they were doing pretty well to start with. It was one of the reasons that they won. It was an application process and they were selected to be our community. And so when we started, we thought we better do a bit of a baseline survey of seniors and in the community itself just to get a sense of where they thought things were at. And we also surveyed the providers. And they were fairly sure that they were doing quite well, even though they weren't fully in experience-based co-design. They had done a lot of work with their own community before this project came along. So we did a baseline survey. It was 800 people, so it was statistically significant. And even they were surprised by some of the results. So it was a telephone survey. It was people 18 years of age and older, so we weren't getting a younger cohort. And we also included caregivers who were moving around with their family members as they accessed care locally. So we had a good response to it. This just gives you a sense of the profile of the people who answered the telephone and answered the questions. I'm not going to spend time on that. And this shows you the frequency of their transitions locally. So we decided to focus on, because the amount of transition in and out of long-term care was fairly small, we decided to focus more on the home, hospital, home care sort of space, which made sense. The largest transition was lab care, but we didn't spend a ton of time on that. So I'm just going to give you a sample of some of the things that people said. So this is the percentage of people who are reporting that they were able to participate in decisions to the extent that they wanted to while they were in the hospital. Now I should stress that this is not one hospital. There are 3 hospitals in that community, so this is not particular to Northumberland Hills. It could be any one of the hospitals in that community. But when we then asked the question about follow-up, so people felt they had pretty good opportunity inside the hospital to participate in decision making, but once they were discharged, they were not followed. This is the percentage reporting that hospital staff took their preferences into account when deciding where care would be after discharge. And then this was their transition plan. This got at the notion of whether the home care manager was working closely with the hospital staff to ensure services at home. You're starting to see the numbers shift now a little bit. And then this looked at the difference between patients and caregivers. So the same question, but patients and caregivers having a slightly different perception of why that's so. Now we didn't probe into why, that is an interesting thing to try to understand, and whether it's because the caregivers are seeing the totality of the interaction potentially behind the scenes, maybe that the patient is not seeing, we're not sure. And then we asked a question about anxiety, and I have to give credit to Patients Canada for this. This was their suggestion when they looked at our survey. We didn't have it in, and they looked at our questions, the ones you just saw, and said, yeah, that's all fine. But what you actually should try to understand is whether or not people are anxious while they're in that transition. If they're anxious, were they able to express it to somebody? And once expressed, could something be done about it? So we asked those questions, and quite an interesting response. So experience-based co-design, as Kelly said, it is one methodology. It's not the only methodology, but it's one that we're quite partial to because it so embeds the patients in the decision-making process, and it starts every improvement opportunity starts with a patient story. So it really grounds the conversation in what actually happened to somebody. So it's not a satisfaction score. It's not there, was this good or bad? It's here is my journey. And then when you unpack that, you can really try to understand the system interactions that may have caused the experience to be the way it was. And it can be good, it can be bad. It's not necessarily all negative. But it really starts from a conversation about what happened to a person. And it comes from the National Health Service in England. This is just their little diagram. And we use their methodology in PATH. We have 5 project groups, all of whom have gone through a process using this methodology. And as Kelly said, it's just one, but it's a very powerful one. It's a structured one, and there's a lot of evidence on very positive impact when used. So I'm going to finish with just running a little video. Well, I'm not going to run the video because I haven't got a clue how to do that, but someone's going to run the video, and it's just people in the Cobourg community who have gone through the experience-based co-design process talking about what that feels like. And then I'm happy to take some questions if we have. I think we have a little bit of time.
Yeah.
Experience-based, co-based design has been a phenomenal experience because it is based in seniors and their caregivers' experience rather than in the healthcare provider experience. And the huge difference and the huge foundational shift that creates for us and understanding what the experience and the impact of something is, where we as providers would not have had that opportunity to know or even asked for before.
It's been exciting. It's brought back my passion on why I'm in healthcare, and it brings back the main focus of why we're here, which is to help our clients.
I have trouble getting enthusiastic about lots of things at my age. I'm very enthusiastic about it.
It was actually quite invigorating to see a number of people from all different backgrounds, that had different backgrounds, come together and work towards one goal, okay, which is a component of a bigger project, of course. So I've never really had such a formal part in something like this, and at least something that's clearly recognized as a component of a project. And so it was really nice to see people really interested in giving their input and kind of working towards an ultimate goal.
Well, I think it's been wonderful, and the main thing is because my case, I was so isolated during it. Suddenly I found all these people who have similar stories, and it just means you're not alone in the world. And that was the big thing for me. And learning that communications is so important.
Very relaxing and eye-opening, and has given me an opportunity to exercise parts of my brain and thought process that have been dormant for a while, and I really have enjoyed the experience. Well, the storytelling. I really thought the storytelling was quite emotional, and I could see the pain. I could almost visualize what they were going through as they're going through it, because I myself have had some experiences, and I did tell my story, which allowed me a chance to open up to others and about my experiences with transitions involving my elderly father, my mother-in-law, and at the time I certainly was doing some caregiving as well, and was out of my role as a physician, so I identified with the storytelling quite a bit.
The most significant part was really listening to the caregiver and patient stories, and it had a very significant impact on me to be able to listen to it. And you know, it goes back to the old adage, walking a mile in somebody else's shoes, and really until you've done that, and you don't know what it's like. And it was important for me to understand the ripple effect that decisions that we make as service providers can have on people, their families, their friends, caregivers. And it was at times very emotional to listen to their stories, and I was very, very appreciative that I got the opportunity.
So I think the PATH project is probably where you guys will be, hopefully, in 6 months, a year, 2 years. They started off with a coalition of providers wanting to understand better what the experience was of seniors in their community, and they brought the seniors in and structured the storytelling and organized project teams to focus on certain aspects of local design and had the patients and the caregivers there as part of the decision making. It really is as simple as that. On the other hand, it's not simple at all. So I'm quite happy to take a couple of questions if there aren't any, or we can move into the next presentation session.
Kathy, could you just share a little bit about how we're having our
Oh, sorry, you told me to do that.
interactive path?
Yeah,
Just
yeah.
people might be interested in
Okay,
that.
so the PATH group is Northumberland based, and our Panorama group, our citizens panels from all over the province. We structured it deliberately so that we had representation from everywhere but the Northumberland County. And they have gotten together over a weekend to sort of look at what they were doing in Cobourg and provide some advice and feedback on the project itself. And they will be getting together again in May because we now have results of what's happened locally on the ground. The other thing I guess I would reflect, this is our 4th session because we've offered this version of this session to every LHIN in the province to be co-designed with the LHIN and the Health Links in terms of what interests might be locally. And I think it's not a generalization to say to date what we're seeing is that Health Links are really keen to try to figure out how to do this. There's a variety of things people have been trying to do, and I'm not talking about the care planning. That's going on everywhere. I'm talking about above and beyond the individual care coordination. How else can we engage patients in the link itself? And there seems to be some who have set up advisory councils, separate advisory councils, some who are using focus groups, some who are doing a bit of surveying, some who are doing telephone conversation, but trying to figure out this stuff where you're really embedding a group of patients in the fundamental decision making of the running of the Health Link. I don't think we've seen yet, but lots of interest in trying to understand how to do that. So I'm not seeing any questions, which is fine. So shall we move on to the next? Okay, thank you very much.
Thank you, Kathy. And Kathy will be here throughout the day, so if you do think of things you want to ask about later in the day, she'll be here to do that. My name is Genevieve Obarski, and I think you have all of our bios in there, so I won't bore you with those details, but I work with Andrew and Kathy at the Change Foundation. And I want to especially thank Rachel Stack for working with me on putting this together. She did lots of work. Rose Peacock worked with us as well, but she's in Barbados and couldn't join us today. And she said she wasn't changing her trip for that. But thanks to the team at the Southwest LHIN for they did all the nice table settings, etc. So I appreciate working with them. It's been fun putting this together. Our next segment, what we want to do is hear from some of the health system users what it's a bit of background of their journey, and both of the folks that I'm going to introduce, Gail Long and Amir Kamali, are involved in engagement activities. Gail with our Panorama panel, and I think has an appetite to get more engaged. She lives in the Waterloo-Wellington LHIN in Cambridge, so she wasn't too far away from this today, and we're so happy to have her with us. And Amir actually has a more formal role in engagement, which he will tell you about. Amir comes to us from Holland Bloorview Kids Rehabilitation Hospital, and he'll be sharing both his journey and touch points with the health system as a father, and then a lot about the work that he's doing at Holland Bloorview. And Gail will share with us a bit of her background and her interaction with the healthcare system. And she had some significant challenges early in her life with raising children and going to school, and then faced some new challenges with the healthcare system, and we'll hear a little bit about that and why she's choosing to engage with the Change Foundation and some other organizations in trying to make improvements in the healthcare system. And just one other note that's a lesson for all of us, we had a third patient that was going to join us today. Actually, she's a caregiver, also from our Panorama group. And part of our support at the Change Foundation for having people join us is to make sure that we cover costs for transportation and lodging if necessary, and also caregiver support. And the woman who is going to join us has her husband at home that she takes care of, and we always pay for caregiver support when she attends functions with us, and she was unable to arrange that for today. I guess there's, maybe because of the weather, the winter, there was... even though we were going to be able to pay for it, there wasn't enough staff for her to have home care support. So she really wanted to join us today, but was unable to just because we couldn't arrange that. But just again, that's one of the challenges of things that we need to think about. And when you get to your planning stage, those are things to think about with involving patients and caregivers in the process. So I'd like to ask Gail to come up, and she's going to stand here at the podium. And I think, Amir, if you want to just sit here, and then you can switch since we've introduced both of you. Gail's going to share a bit about her healthcare journey and at this stage why she's engaging with the health system. And then we'll hear from both Amir and Gail a couple more times during the day. So welcome, Gail and Amir. Okay? Okay.
I'm fine. This is not something that I do easily, but I'm getting better. I want to thank you for being here and listening to me. I promised I was going to make this fun. Over the years, I developed some severe leg problems, obviously. And so it became a battle about which was going to come first and how was I going to continue. And I didn't have any problem getting my knees replaced. That was a period of 10 years in between doing the operations. And it was basically a good experience at a wonderful hospital. I have nothing but good things to say about healthcare providers, particularly nurses. A little less about doctors. But anyway, the knees are fine, the knees are great, but the feet fell apart. And they were the course of the problem all along, but nobody knew it at that time. So I started looking for doctors to work on my feet. And my first two approaches were right in my community. And both orthopedic surgeons looked at it and said, no fixing that one. And they both said the same thing, no fixing that one. So I thought, well, I have to go further afield. And my family doctor, who is remarkable and worked with me personally throughout the entire time I was at the mental health clinic in our local hospital, so we care a lot about each other. And she's been wonderful. She didn't know any orthopedics outside of my community. So I went and did some research, did what I could, found a couple of names of doctors that were highly respected and were doing work on feet. The first one was not too far from home, and I went up to him and he said, oh yeah, I can fix this. This is no sweat at all. I looked at him with great amazement. Of course, a few years had passed in this process. And so I thought, good, I've waited long enough. They've got something, they know what they can do with this. And he said, the operation's no sweat at all, but you'll have to go home and you can't put your foot down for 3 months. I don't want you to ruin my good work. Okay, so I'll set up, I live alone. I'll set up a process whereby I can manage on my own. I have severe arthritis in my hands and my wrists. I can't manage a wheelchair. I can't use crutches. I can't use an ordinary pickup walker. I have a walker, but it's a rolling walker, and I manage with that. But trying to find healthcare providers that would be set in place and organized so when I went home, because it was only overnight surgery, it wasn't extensive, but they insisted that I couldn't make arrangements until the surgery was done. I don't know about you, but if you're going home to a house where you can't get to the toilet and no arrangements have been made, that's a no-go. I can't do that. Yes, I have family. Yes, I have friends, but that's not where I wanted to be. I don't want them helping me into the toilet. My ultimate goal was that even my family doctor tried to talk to this agency that was to provide the care. No, they do not talk to you until the surgery's done. This was going to be overnight. Knowing my history with anesthetics, there was no way I was going to be able to talk the next day, let alone discuss what care I was going to need. I needed to do that beforehand. So no surgery. The orthopedic surgeon wasn't the least bit interested in talking about it. It wasn't his business. So, no surgery. In the meantime, I had this other referral out there somewhere which I'd completely forgotten about. My family doctor had completely forgotten about it. I put it on the back burner and said, I'm not going anywhere for any time soon, and I'll live with this. I'm still living with this. 7.5 years later, I told Change Foundation it was 10 years, but it wasn't 10. When I looked at it, it was only 7.5 years. I'm a very patient person. I got a call out of the wild. Absolutely didn't know anything about it. It was this doctor, secretary wanting to set up an appointment. I said, what appointment? And they had to explain to me what they were talking about. I was overjoyed, but a little bit puzzled. 7.5 years for a referral? Finally, after one cancellation on his part, I finally got in to see him. Yes, no problem. And no, they didn't understand about they could do the surgery. He thought it definitely had to be done. And it would work just fine. And I wouldn't be going home right away. They would take me into a rehab rehab facility because there was no way they were sending me home until they figured out how to maneuver me and how to get me mobile. That was 2.5 years ago. And I'm still waiting for the call for the surgery. In the meantime, when I started this, I was going on 65. I'm now 75. And I'm saying to myself, I'm not going to do this. I don't react well to anesthetic. I'm an old girl. It just doesn't feel right. And if I spend 3 months in a wheelchair, what's the chances I'm only ever going to get up and walk again? I can't sometimes get out of bed in the morning without a great deal of creaking. So I haven't told them. I've called them 3 times and left messages and said, am I even on the list? And no one has ever gotten back to me. I actually was in the hospital one day and I went up to the office and banged on the door, nobody there. So I went down the information desk and asked them, is there ever anybody in that office? And the lady very nicely said to me she didn't think so. But the doctor was still in the hospital. Of course, I couldn't see him. So that's totally unresolved, and it just leaves me puzzled. 10 years, a lot of time that has been spent, not on my part, but on the facilities parts. And nothing was resolved, and nothing got done. And I don't think that's terribly, terribly unusual. The unusual thing is that most old people like me, most chronically ill people, aren't quite so dogged. You know, I'm determined. And if I'm going to do something, I'm going to do it. It might take a while. The other thing I wanted to comment on, I've got time for just a, pardon? Yeah, for just a few minutes, is another aspect of my care, and this one might be a little bit touchy. And definitely a little bit touchy. Since the time I was about 55, I had real gut problems. A lot of people, I'm sure, in this room understand what that means. And I was going around, if I had a complaint at all with my family doctor, it was, well, what am I going to do about this? It seriously interfered with my life. My social life was non-existent. I was afraid to go anywhere. I didn't trust myself to go anywhere, to do anything. And there was umpteen colonoscopies, umpteen appointments with gastroenterologists. And one gastroenterologist told me that I had lost the enzyme in my stomach and I should never eat raw vegetables again. So for the next 5 years, I didn't have a salad. You know what that feels like? But he didn't know why the enzyme wasn't there. It just wasn't. Nothing turned up in the colonoscopies, for which I was very grateful because I'd had a bowel resection in '88. And that's something you don't want to go through again. And so I was reaching the point where I was on insulin. I had diabetes. I was massive blood pressure medication and cholesterol medication. And I was barely being able to get around in my own apartment. I knew I was dying. I was on my way out. I told my daughter, I am going to go, I can't believe I'm saying this, to a naturopath. And I did. I pay for it myself. The first appointment, she said to me, after she'd spent 2.5 hours with me, 2.5 hours. Where do you ever get that? Didn't cost me any more. And she said, would you consider giving up weed? I said, giving up weed? What are you talking? Yeah, why? She said, I've got a feeling you're really celiac. I want you to give up wheat. Tell me how you feel. Come back in a week. I phoned her in 3 days and said, I haven't felt this good in 17 years. It's 2 years later. I'm wheat-free. I take no insulin. I'm on very little blood pressure medication. My cholesterol level is perfect. And I have the blood work of a 20-year-old. Inadvertently and totally unplanned, I lost 22 pounds, which is great. And certainly has something to do with, but I lost that 22 pounds in 3 weeks. And the only thing that changed in my life was that I had to give up weight. But the blood tests, I had to go back on it to take a blood test to confirm that I was a celiac. And I'm a raging celiac. I went right off the charts. And I'll tell you, I did go off the charts. But anyway, now I'm fine. Just don't give me anything with wheat and I can't lick an envelope. So, I have some issues with the medical profession. My family doctor is wonderful, as I said. She said to me that during her training, she had 6 hours of nutrition counseling, of nutrition training. She knew nothing about it, but she was now referring a lot of her patients to try going wheat-free. And she uses me as an example. 20 years of absolute misery that really interfered with my life, that didn't have to be. So, I want to talk to you later in the afternoon about where this all led to Panorama, and my thanks to them. I'm so glad to get an opportunity to pay back. I owe the taxpayers a lot. I said it, so I'm taking it.
And share some of the formal engagement strategies that he's involved in at Holland Bloorview. Both, you know, he's kind of wearing 2 hats today. He's an involved dad caring father, but he's also an employee at Holland Bloorview to foster and get more families involved in all of their operational work. So we're going to hear a bit about that, and then we're going to have Gail share with us the engagement that she's done so far with the Change Foundation, and what that's like for her, and what are some good strategies for engaging with people. So hopefully we'll be learning from both of them. So Mary, you're first off this time.
I get to go right after lunch. I had to go after Gail first, now I have to go after lunch. And we're gonna have to work on this agenda for next time. Thanks everyone again for having me up here. Before I start talking about what we do at Holland Bloorview in terms of family engagement, I do want to share that what I'm about to share is not meant to overwhelm you, not meant to make you feel like you're so behind, or some people are just starting. And whenever I'm asked to present on the work we do there, it's a little bit awkward for me because I think we have a really cool program down there. However, my conversations always tend to go towards where we are at a system level, not where Holland Bloorview's at. So the reason I do want to share the work we're doing is more to inspire everyone and to share that we can do this fairly easily. Yes, there's complications, but we're doing it. We've seen a lot of success, so it's more around that piece that I want to share with you. For those of you who don't know, Holland Bloorview is Canada's largest kids rehab hospital that has about 600 inpatient visits, about 58,000 outpatient visits. I think we're coming up to 70,000 now. And we work with children with brain injuries, spinal cord injuries, development delays, learning delays, CP, autism. And so that's the kind of rehab that we do. The general inpatient stays are around 3 months with us. So we don't have the challenges that some of you do in the larger hospitals. You'll see in our values, client and family-centered care is there. The organization has made a commitment to client and family-centered care. It's the way we live, the way we breathe, and I just don't know how else to do it. I don't know how else we would do it. I haven't seen it before that. I joined Holland Bloorview. This was already in place, so for me, this is how I learned to work there. It's an extremely special place. We had a conversation during lunchtime around when you walk into this building, there's a different feeling. I think part of that is a commitment towards client and family-centered care at the hospital. And in the heart of client and family-centered care, there's a program called the Family Leadership Program, which is the program that I lead. I did not design the program. I'm not here standing up here taking any credit for designing it. However, I hope that I've added quite a bit to the program from when it was first established. The program in its current state has about just over 100 volunteers. And we talked a little bit about putting a sort of a list together. We have a pretty formalized data system that we've worked with our volunteer resources to manage that information. And we have the family advisors, family mentors, family is faculty. We have a youth advisory committee. And yes, we have a children's advisory committee. And my latest body of work is the Bloorview Research Institute Family Engagement Committee, which I'll share with you a little bit about what we're doing there, because that's some pretty exciting stuff there as well too. The family advisors currently sit on over 30 committees in our hospital, so every standing committee in the hospital is mandated to have families on it, and the majority of them have 2. And if they don't have 2, the reason is one family member had to stop working because something has happened and they just can't do it. So we're then looking to backfill that. There's 17 projects, special initiatives, redesign of a program, redesign of a room that we have families on, and we have 5 external committees that our family leaders are sitting on, including our LIN. And the family advisory for the Northeast LIN is co-chaired by one of our family leaders, and he's also the first family leader on the Northeast Advisory Committee. We have the family mentors at the hospital who provide the peer-to-peer support one-on-one at the hospital, Monday through Friday from 9 to 3. This is what really helped me in my journey, so I'm a big fan of this. For me to be able to talk to another family and get their perspective and their journey. And I'll give you an example. What I mean by that is that when I was going through all this, I would tell my parents, I'm going to go work on an IEP for my son, and they can sympathize, but they couldn't truly understand what that meant. What does that mean in terms of all the other millions of appointments that I have? What does it mean in terms of the emotional challenge I'm going to have having this conversation that I'm going to be working on this IEP? Because remember, it wasn't part of my plan, right? So it really helped me to actually have these families. And when I first said it to a family there that said, I got to go and work on the IEP, I could tell by their reaction and the way they just said, oh, I remember that they got it. They got what this meant to me emotionally, physically, what it meant to me in terms of all the other things that's happening in my life. Big fan of that. They also run our inpatient and outpatient talks. We do monthly talks for outpatients. We do weekly talks for inpatients, and we do a monthly talk for, we just started with autism spectrum disorder talks, because that's really a hot topic right now. We have families faculty, which is another really big role for us. They share their experience, telling stories at new staff orientation, and it's really geared around client and family-centered care, and what their experience would be like, and how it impacts them as a family, and when they receive client and family-centered care and when they don't. And that, we heard earlier how wonderful that is in terms of setting the right mind frame for new staff coming in, and they're all, and the same as earlier we heard, the evaluations are always, that's the best part of the story. They present nationally for us. They've presented at almost every conference that has come about in the last 2 years. And we've actually got to a point where we kind of just send them on their own. And we're not scared anymore that they're going to say something, because they've been trained, and they've been supported, and they understand their role, and they understand that at the end of the day, they're bringing a family perspective. However, it's coming from a Holland Burvey perspective. And so we've done our work to get them where they need to be, where we feel comfortable they can go to speak, and we don't have to oversee them anymore. We are currently developing 4 simulations for client and family-centered care. This is really big for us. We will be delivering a half-day training for all clinicians that will actually sit through 4 scenarios based on the 4 core principles of respect and dignity, participation, inclusion, and collaboration. We've worked for about a year now to make these scenarios authentic, and we're looking forward to having these new staff sit in there and really feel what client and family-centered feels like. So we've taken this concept and trying to make it really real for everyone. And we're also in works with the UFT. We're also a teaching hospital. So we have a lot of students from UFT, and we're talking to UFT right now in embedding some client and family-centered curriculum in the training. And so when we talk to these students, we have a medical home visiting program that we've into our 3rd year now, where all these students from UFT get an opportunity to spend an evening with the family. So they go over to the family's house, and we've heard about the power of actually going to somebody's house and doing the work there. They go there, spend 3 hours with the family, and then they get to follow them on an appointment as well too. And they've all come back, and one student had actually said, I don't remember what I did in the first year, what I learned, but I do remember that experience. That's scary in itself, that they don't remember what they learned the first year. However, they remember that experience. So another really powerful way. So we are working with the UFT to try to develop some of that training. And a lot of students have said to us that they got into the field because they wanted to just take care of people and help people. But all the training, there's none of that in the training, right? And so when they come out of there, they don't feel equipped to do what they actually wanted to do. So it's a really good opportunity for us to be trying to embed this curriculum at a university level. We have our Family Advisory Committee, 30+ members that meet on a monthly basis, and they're the ones who really drive client and family-centered care. They're becoming advisors and consultants to the hospital, and they're the ones who actually shaped this program. They've been around for almost 20 years, and they were getting calls for, I want to engage with you here, and they were getting overwhelmed and said, we need to formalize this program, and they're the ones who kind of worked together and put this program together. At that meeting, the CEO is usually there, the VP of Programs and Services there, the VP of the Blairview Research Institute is there, the VP of Communications is there, 30 family members are sitting in the room, we have a board member that comes in, and we have a ton of external partners. So, and it's a working committee. It's getting to a point where almost every 20 minutes they're giving us feedback on a new program or a new service. They're feeling a little bit overwhelmed, so we need to kind of back it up a little bit. But the amount of feedback we get in a 2-hour period is absolutely phenomenal. The Children's Advisory Committee. I love talking about the Children's Advisory Committee. You think about really listening to people. And I tell you a little story about the Children's Advisory Committee. We've done 2 projects with them. And the first one we did was a play and learn model where we have a Ronald McDonald Playroom. We had them come in and we had them play in the Ronald McDonald Playroom for 45 minutes. And then we took them and had pizza. And while they were having pizza, we said, tell us what worked really well and what doesn't work really well. And there's a 6-year-old girl there that uses the playroom all the time. And we have a ball pit in this playroom. And in that ball pit is where every kid wants to go. It's not where every kid wants to go, it's where all the staff want to go, and that's probably where you're going to find me on those really stressful days. I'm probably sitting inside the ball pit at some point. And so all our staff, we kind of want to get in the ball pit when we're having those tough days. And she tells us that she's never been into the ball pit. She's been going there for years, and none of us really figured this out. So we asked her why she hasn't gone in there, and she says, well, we had this little bean bag that was really kind of cool for kids to sit on, but she couldn't actually manage to get herself up there. And so we asked, why didn't you ask Daniel? She has such a great relationship with the person taking care of the playroom. Why didn't you ask Daniel? She goes, I want to do this on my own. The next day, we had a ramp. She got to go in the ball pit, right? What that meant to her for her confidence level and just being able to say to her friends that she's been in the ball pit, money can't buy you that kind of feedback, right? And so tons of success stories through there. The other one they did with us was a food tasting. You want to hear honest feedback? Get a bunch of kids to try some food. And the way they did it was they actually got, smiley faces, sad faces, and they had to circle how they felt about the food. Is it gross? Is it yucky? Is it edible? We weren't saying is it excellent, right? Or is it good or is it bad? It was like, is it gross? Like, we got gross quite a bit, right? Gross, it's yucky. And the feedback also came out like, I'm not touching that. Okay, I think she thinks it's gross, right? So you can see some pictures here of getting some feedback from the kids. And this is actually the young girl who told us that she'd never been in the ball pit. The last thing I talked to you about is the Bloorview Research Institute Family Engagement Committee, which we've been in the works for about a year and change now. And we put this committee together because we wanted to engage families in research. We thought that's the place they need to be as well, because that's where the programs and services are going to start flowing down from the research that's there. However, when we started that, we invited 10 families to join us. We sat at the table and we said, what do we want to do? We put the terms of reference together. We put our first year goals together. There wasn't anything that was done that we actually drove. And we didn't say that this is what we think we should do. What do you think is important? And it's been a year and a half work that we've been working on. And it was yesterday that we actually agreed upon a framework of what this is going to look like in terms of engaging families. So when we talk about getting families started at the beginning, we talk about getting families started in the conversation of even setting the goals of what this committee is going to look like. What's the purpose of this committee? We didn't come to them and say, this is what we want to do. We want to say, what do you think is important to you? Here's some of the things that are important to us, and how can we make this committee work? So it's been a year and a half, a wonderful project. We're looking forward to that. And we've done a systematic review with this. If anybody wants to see the results from our reviews, feel free to reach out to me and I can share that with you. I'm going to finish off by showing you a video that the families and I put together, highlighting the work that we do. At the heart of Climate Family Centre Carrick Hall in Bloorview is a family leadership program. Our volunteer family leaders truly are part of the team. They share their lived experiences to help us improve the quality of care we provide. Our family advisors sit on every committee, and there isn't a project or initiative that gets started without a family advisor at the table. Our family mentors provide the peer-to-peer support. This is integral to the healing and overall well-being of our families. Our family educators help the staff and the broader community by sharing their stories so healthcare providers can see it from the family's perspective. And finally, our Family Advisory Committee works with the senior management team to ensure that client and family-centered care is not only embraced, but embedded throughout the organization. It's in these partnerships where meaningful changes and improvements are made.
We take our role very seriously in advancing client and family-centered care. It's about the experience of the client and their family. And as such, it's understanding that we have to co-create in partnership with clients and families the journey that they're on.
We need to hear from those clients and families about what it is that they want and what's going to be meaningful for them.
There's not just one person working on something. It's like that we're all together, we know what's going on, we know how we can make things different.
Truly being heard and being listened to.
There is an understanding that all the parties, whether it be staff or leadership or family members, have a wealth of knowledge and experience, and that experience and that knowledge is valued and is woven into the decision-making process that is a shared one here at Allenwoodview.
It truly is involving them in every aspect of the work. When we create a committee, they're involved at the very first meeting, and they're active participants and true members of a committee or a task force or working groups.
It's real lived experiences, and to bring that forward, it's actually very rewarding. When we look at things, we're not just looking at from an administrative perspective, but from a real life perspective as well. And it's all about that partnership of working together.
It's a wonderful feeling to come here and be validated and also be offered different opportunities to grow and to help in affecting change in the organization. That's very powerful.
It's about the expertise that comes from the staff. It's about the expertise that comes from the clients and families. It's about that meaningful engagement and partnership between both. And that's going to be unique from organization to organization, but unbelievably meaningful, not only for clients and their families, but for the organization as a whole. It will inspire your staff to do better, to become better, and to ultimately have a better organization overall.
I'm going to leave you with one thought, and I'm going to take off my Hollenberg staff hat, I'm going to put on my dad hat. And what I want to leave you with is, I know we have a lot of conversation around, we don't want to burden families with more, and we don't want to ask them to give us more, and like we're going to ask more of their time, and I'm going to ask his dad to volunteer, and he's already got a son that he's got to deal with. My perspective, being part of this program and being able to volunteer was a huge help in my mental health and being able to cope with what was going on. So don't be afraid. If they don't want to participate, they'll tell you no. Don't be shy about that. I'll leave you with that. Thank you.
Thank you again, Amir. And now I'd like to have Gail come up. We heard a lot, especially in the video, about how the staff and the family feel about this level of engagement, which clearly is pervasive in the organization. And now we're going to have Gail share with us a bit about how she feels about being engaged with trying to make improvements in the system and ways that work for Gail and folks like herself to be engaged with us. So, Gail? And we'll have a little opportunity for Q&A with both of them at the end of this.
Oh, fun. Talk about a hard act to follow. And I apologize for the Christmas colors, but I was freezing. And I did have a shawl with my coat, so I went and got it. And green and red you got. Okay, I'm going to start off by talking about a little bugaboo of mine, and I'm not quite sure how you'll feel about it. I have developed some strong feelings about patient-centered care. This will come as a surprise to the foundation, I'm sure. But and they don't influence what I say at all. They have no idea what I'm going to say, do you? And that's one of the things I like about being part of the foundation. I looked at even some of the slides today. I looked at those, and I'm always in the center, and everybody's around me. That's patient-centered care, which is great, and I was very, very pleased about that for the longest while. I thought, that's really going to work, that's different. Now I have a different perspective on it because I want to be part of the team. I don't want to be in the center with everybody revolving around me. I want to be there, and I want to be part of it. I'm not young, so I'm an old girl telling you that I can change, and I can be part of my health care. It's important that I be part of my health care. It's essential that I be part of my health care. What you were talking about, Emerald, with the Blue Review and all your family advisory groups and things like that, do you have any, well, you do, I know you do, and people in this room I'm sure do, how empowering is that to someone to say, I'm part of my health care, and if I'm going to stand up to the doctors, never had to stand up to a nurse, the hospital, whatever it takes, I'm going to stand up and say what's really important to me. This is my body. I live in it. You don't. I know my body better than anyone in this room and anyone outside this room. And if I don't, the older you get, the better you better learn. There's no doubt you're going to have to know what's going on with your body. So that's just something that you may or may not agree with. I don't quite know how to make that different. I love everything you're saying about the ABC. I've forgotten what that means. Which is...
Oh, the PDCA?
No.
Oh, experience-based co-design, yes.
Yeah, experience-based co-design. Hey, that's right up my alley. I've got lots of experience. And I can do this, and I feel like I'm part of the team. Some of you don't feel that that's important. I'm sure you don't feel that that's important. But I'll tell you, you get great results because we'll work awful hard. And we don't need to be paid. It's our body. We care about it. So that's one of the thoughts I want to bring to you. You didn't know I was going to go there, did you? Another thing that may be contentious, and I've been giving a lot of thought to it since our last Panorama panel meeting, and there's been a lot of talk about privacy issues and the whole new spectrum of medical records being all put on a computer, whatever they're going to do with it. I thought about that long and hard, and I had lots of trouble with the privacy issues. And I have no doubt that there's going to be a lot of problems with the doctors coming to this decision. But quite personally, I want my record, my medical record, in my hands. Wherever I go, I want it with me in my phone so that I can access it. And if I get in a car accident, either I can access it or there's a universal code that accesses the medical record. It goes with you. It's no longer a privacy issue because I got my record. Nobody else has. I know that's really, really different, but it does solve the privacy issue. And I just wanted to bring that up because I'm mulling it over in my head and working it out and saying, that would work. Now, you're talking about people that come from different generations. And I know that the older folks, I'm not one of them, but the older folks, they come from a generation, and so do their doctors, where the doctor was God. And you didn't, whatever he said, or she said, I have a female doctor, whatever they said was the Bible. And you did what they were told, and you never questioned it. I've had a doctor say to me, I ask the questions. You just listen. We didn't get along very well for very long. So when I stop and think about that, I say to myself, yeah, but that's old school. And the generation such as mine is pretty old school too. But we're dying off. And what you're coming to is a generation of young people, or younger people. Practically everybody's younger than me these days. But it's a generation of young people that have a lot of education underneath their belt. They went to school. My grandfather, I'm sure, never finished high school. Everybody finishes high school now. Most of them finish university or college. They know what they want. And they don't want the doctors and their medical providers to be gods. They're not going to stand for it. So it's no big deal, you know, to just know that this is going to die out. And the more we push and the more we accept the fact that there is going to be patient-centered care, which, you know, I just don't like that phrase. But there is going to be patient-centered care. And the private records, my private medical records, belong with me. I need to be involved in the decision-making, and I very much want to be part of the team. I don't want anybody doing it for me. I don't think I'll change as I get older. I might even get worse. I hope so. I wanted to thank the foundation because they've given me an opportunity which I'm sure would never have come to me any other way. They keep telling me that it was random selection. But there was some bit of unrandom selection in that had nothing to do with me and nothing to do with the foundation. I still think that there was a higher power that somehow or other put us together. And I'm deeply, deeply grateful. I know I'm supposed to come back at the end of the program, but we're all getting tired and we've got lots to do. So I think I'll just say what I need to say right now. I think I've said what I need to say. Okay. And then I won't have to come back and you can go home earlier. Is that okay? Okay. This is another one of my pet peeves. There is no normal. I'm not normal. You're not normal. Stop thinking of people as normal. Each body is unique and is a system. There is a system in place that runs that body, and your system doesn't run like my system. It doesn't run like the doctor's system, but it certainly runs, and in most instances it runs fairly well, and it'll let you know if it's not running well. I'm a living example of that. I live in this body, and I said this previously. No one knows the body better than I do. So heck, I deserve to be on the team. I do have something to contribute besides just this body. So that's why, another reason, I need to be part of the team. So let's look at it this way. We as patients are not here to fit into your box or your circle, whatever you want to call it. We're here to help you realize there is no box. Thank you.
Thank you so much, both to Gail and Amir, for sharing their stories. Obviously, you know, some of parts of that touch our heart, hard to listen to, but we just wanted to demonstrate the power of listening to the impact, as Kelly referred to, and you heard in the PATH video, of the decisions we make and the signs that are up, and looking at that from a different lens. And it's sometimes as challenging to go find people in your HealthLink or your community that want to do what they've done today and given up a day to come and share that with us. But there are people out there that want to do what Gail and Amir are doing, and that is give back to the system, celebrate the stuff that went well in the system, encourage that behavior, and help us make it a better experience for the other Gails and Amirs and their families out there. So thank you very much for sharing that with us. And we probably all need a little bit of a deep breath at the moment. We're going to have a break in about a half an hour, but Before that, we're going to hear from my colleague at the Change Foundation, Andrew McLeod, who has been working. He organizes all the activities for the Panorama Group and was very instrumental in recruiting people to that group. And he's going to talk to us about some of the basic principles of engaging people in our work, some of which you heard in the flesh from Amir and Gail, and talk about the spectrum of involving patients and families in work, and some of the underlying principles of what works and why it works. And one of the documents that was on the left-hand side of your folder is the IAP2 Principles of Engagement, and you might want to pull that out while Andrew's speaking, because he'll refer to that several times, and there's lots of good solid theory in there. So I'd like to invite Andrew up to talk to you, and I'll be switching the slides.
Hard acts to follow, right? As Jen said, I have the real privilege of working with the Panorama panel at the Change Foundation. The foundation's got a sort of double-barreled perspective when it comes to community engagement, because we have both this practical, on-the-ground experience of working with a citizens council, a patient's family, whatever you want to call it, as well as doing some thinking and research on the subject of community engagement and the practice of engagement. So I'd like to sort of draw on both of those perspectives today. And I want to come back to the comment that was made right at the beginning about the language. I make a point of including this, and you'll hear me say community engagement a lot. It gets called patient engagement, it gets called consumer engagement. There's all of these words that are not quite interchangeable and mean certain things to certain people at certain times. I tend to use community engagement because it's probably the broadest umbrella that will include patients, family, consumers, clients, whatever the language is that's appropriate, but also need to keep in mind that it includes stakeholders and staff, because anyone will tell you that the dialogue is most valuable when the engagement is including all of those groups, because they usually I'm going to save that for later. They usually enjoy speaking to each other, and it's certainly a request that our panel has made of us. And we want to talk to these other groups while we're talking about the issues involved. But there are particular needs that need to be considered, particular design considerations for some of these subgroups. And we do want to sort of think today about patient-client engagement, or and not patient, family, consumer, client, all of that piece of the circle. So I will bop between those words, but I'm really using them to mean mostly the same thing today. I wanted to start with some first principles, the bedrock of patient engagement or community engagement. And there are a few. This is one that gets used quite a lot. It's a perspective of principle, nothing about me without me. Not everyone agrees with that all of the time. I want to declare my bias that I do. It's probably not surprising, but it's language that will come up again throughout some of the things we talk about today. There's also this one, IAP2, how many people have heard of IAP2 before they saw the sheet with the spectrum on it when Jen pointed it out? Okay, so not very many. Good, so I'm in the right place. This is a position that IAP2 takes. Good decisions don't just happen. Engagement is about decision making, should be. And good decisions are based on good evidence, on a breadth of evidence. And as you've heard already this morning, the challenge I have of following Gail and Amir, there's a great depth of evidence and experience, and knowledge through experience, and perspective on solution that's available to all of us through community engagement techniques, patient engagement techniques. It's not just an exercise. It's not something that's the LHIN is simply requiring or that the government is simply requiring. There's tremendous value in community engagement when done well. And so that's really what I wanted to talk a bit about today. The thought that struck me as I was looking at you've got this in your package as well from BC. Just on page 3, there's the section about domains. And so I wanted to make sure I spoke to this as well. There are 3 domains for engagement. And the first is critically important. But really, I should also say that when I'm talking about community engagement, I'm really talking about program and service design and system and community. The larger discussions of engaging patients or clients. So the focus of this work and the IAP2 materials that you have are sort of assuming those 2 domains rather than the first. And I just wanted to note that because I know patient engagement is often talked about in terms of patient activation or working with an individual patient in their individual care plan or their individual journey. That's critically important, but not quite the same thing, and I want to make sure those 2 don't get confused. IAP2 has a set of core values, which I'm paraphrasing here, and I won't actually go through, but a set of sort of fundamentals to look at and examine. Some of them are real value principles. Those who are affected by a decision have a right to be involved in the decision-making process. That's nothing about me without me again. Some of them are more directive in terms of good practice for community engagement. If you look at number 7, communicate to participants how their input affected the decision. I'm going to come back to that in terms of communication and transparency. But this is a tremendously valuable set of values, principles to look at. IAP2's material is all available online, and I wanted to flag that at the start as well. This is the spectrum that is in your package. I've lopped off all the lower stuff, the goals, the promises, and the techniques, but I'm going to talk about that as we go through it. There are a couple of other spectrums that we like to draw attention to. The first is from Peyton Robert in the UK. It's a spectrum of patient experience. And I love using this in combination with the first because the first is what you can do as the one holding the decision-making authority or tasked with developing solutions for a decision. The second is the reaction. And I want you to think that whatever decision you make about the degree to which you involve those who are affected by the decisions you're making, you are leaving a space for those who are affected to do something as well. So this Peyton Robert spectrum, I know it's small there, on the left, it goes from complaining, which is if all you do is inform them, whoever them is, then all you leave for them to do is complain. Nothing else to do except complain about the information you're giving them. If you consult with them then you're inviting them to provide information. And it's not a direct corollary. These two aren't really meant to be fused together the way I am. But, and that patient experience spectrum goes all the way to experience-based co-design. So you are automatically creating a space for your patients, your clients, your families, whatever choice you make around decision making, what you are leaving for them to do. And the advice is create a space for them to do something positive, proactive, collaborative, rather than simply leaving space for them to complain or go to the press or whatever it is. The third is from Barbara Balick in the US. Barbara's come to speak at events sponsored by the Change Foundation. This is a spectrum that we sometimes go into more detail on, but I'm not going to do that today. But from a health provider perspective, this evolution of going from doing to, that very sort of paternal, doctor knows best, we will tell you what to do, the compliance regime for your medication, you will comply with what we tell you to do, through doing for, which is a much more benevolent, but still, a good intention, but we're going to do this for you, to doing with, which again lines up more with co-design, with empowerment, and when we're talking about service design and planning, doing with is really inviting those who are going to be going through the processes we set up the chance to be involved in developing how that process should look. So 3 to think about. I'm going to come back to some references at the end where to find all those things. So in terms of basic principles, how many of you in your individual organizations, I know the health links are at a sort of a variety of stages, but in your individual organizations, how many of you have patient engagement or community engagement or a client engagement, whatever the language is, plan in place that you use as reference for working with your clients on how things, how your process are going to be organized, how you involve them? 1, 2, okay, so a few. How many of you who put up your hands think that you've got it, that it's totally sorted out, it's working as well as it could? You basically are in a position to really keep doing what you're doing and it's working well. No, but good, it's a trick question. You're not supposed to answer yes to that. How many of you have been thinking about it in some capacity? There's either some discussion in progress or some document in draft format or some other organized thinking around the subject of developing a plan to put in place? There's a few more, right? How many have not been thinking about it at all organizationally? I mean, I don't mean that you haven't individually been thinking about it. And I know that there's a lot of individual engagement where people get drawn into particular things at particular times, but it's, I think, fair to characterize it more as ad hoc rather than an organized standard process. But how many of you don't have an organized standard process or haven't been in the process of developing one? Not many either. So what am I missing? What are all the other hands? Just shout something out. Where are others in their thinking about patient engagement or client engagement? No?
I think we do. It's just not been formalized.
Okay, yeah. So it's kind of a thread in there.
Yeah.
She said that they do. Where are you from?
From the multi-service centers.
Okay. So an organization that does this, but it's not been formalized.
Yeah,
Yeah.
exactly. Because we have a process for bringing clients on and we give the information. But again, I've seen here we need to go further with client engagement.
Well, so one of the things I want to stress, it actually just occurred to me this morning, just sitting at the table, is that adage about a journey of 1,000 miles beginning with a single step. You'll hear lots as you begin to explore community engagement, patient engagement. We certainly have examples of really wonderful stuff that's being done. and really well-developed, mature processes that certain organizations have that are to be aspired to, for sure. But what I want to say is that the principles today are meant to be a starting point, a way of getting going. And so this is the first. Start before you're ready. The organizations who are doing fabulous work will tell you that they weren't ready when they started. I would say that nobody's ready, and often people use readiness as a excuse rather than as a true building block. There's a lot of opportunity to create a virtuous cycle of engagement. If you begin honestly before you're ready, and you begin by saying we're not ready, but we're going to start anyway, then almost all the time, if you're honest and genuine, you will be rewarded by individuals who are interested in getting involved to help do things better. Even if you start by saying, we don't know what we want to work on. When our PATH project got started, we had this challenge of trying to begin a project without yet having had the conversation about what we're going to work on. But to say we want to do a better job, we know that there are challenges. Opening up and being honest about that is certainly a challenge, especially to those that we serve. But if you do that honestly, folks will come along with you. And then you can build more involvement as you go along. Sort of along the same lines, start at the beginning. You will invariably find that if you wait until you identify the 3 options for the solution that's at issue, and then you bring those 3 options to your community or your patients or your constituents, whoever it is that you serve, and say, which of these should we choose? They will invariably say, these are not the 3 answers. Why didn't you consider that? Why isn't this on the list? How did you even arrive at these solutions? It's part of just the human cognition process. Even if you have exactly the right 3 solutions, there are no better solutions, there are no other available solutions. In order to understand them fully, you got to understand how you got there. You can never start involving people too soon, again, as long as you are honest and transparent. You can often do it too late, and you will have to backtrack in order to come back around, even if you've got it exactly right, although you may not have. We often jump to the question of technique. We often say, what do we need to do? How do we need to do this? Just tell me what I have to do it well. And those are good questions to ask, but they're not the first questions to ask. I would say you have to consider the who, the what, the where, the why, and the when before you get to how. IAP2 has a catalog of techniques. There are more than 100. And they are formulated to hang off of this spectrum. So you have to have an honest conversation about the degree to which you are willing to involve the people you are seeking to involve before you can get to a technique that will be appropriate. Kathy, for Christmas last year, gave me the Cartoon a Day New Yorker calendar. And I can't remember what day of the year this was, but as soon as I got to that day, I ripped it off, I marched over to Kathy's office and I said, this is perfect. So if you can't read it, It's a gentleman at a podium and this line of people at the microphone, and the gentleman at the podium says, "We'd now like to open the floor to shorter speeches disguised as questions." This is a town hall. Right? It's a common engagement technique. It's a valid engagement technique, but not in every situation. In fact, not even in most situations. Most of those who have done their share of community engagement have hosted or organized a town hall. Many of us have sat through a town hall. I know I have. And I know that I've sat through a town hall as a member of the audience where I thought, this is useless. No one's benefiting from this. They're getting beaten up. I'm wading through all of these folks who have a particular agenda that they're trying to advance. It's not getting us anywhere. And as a participant, I've been frustrated by that. I was looking for a genuine opportunity to either be informed or contribute something. This wasn't it. Sometimes it can be, but it will only be the right solution if you arrive there after asking, who should I be engaging? How am I going to engage? Why am I doing this in the first place? Where and when are appropriate? That may lead you to this, but not necessarily. Town halls are actually 1850s technology, right? Surveys are 1950s technology. There are new solutions available. Don't ignore the new technologies that have been developed in community engagement practice. And even the technologies of communications technology. There are lots of online tools available. In fact, the panel uses a few of them because our group is so disparate. It's not financially viable or even appropriate to ask all of the 30 members of our panel to come into any one place as often as we'd like to talk to them. Technology is a solution that gives us the chance to talk to them more often without being so demanding of their time and energy. Don't take participation for granted. There's a lot of goodwill, a lot of interest and motivation to participate, but that will only take you so far. You can easily burn out the interest in participation, the goodwill that you have in your community, the motivation to participate. You need to think about the value proposition for those you are inviting to participate. That's not simply code for dollars and cents, although, as was mentioned before, the foundation at least has tried to construct a model where the costs involved in participating are mitigated. But you want to look at how you are going to honor the time that participants have volunteered and how you're going to articulate the opportunity that you are offering to be involved. That requires first having an honest conversation with yourself to make sure that there is a meaningful opportunity to contribute, and it isn't simply an opportunity to air grievance, and then that's the end of it. And then, as I mentioned, that seventh principle in IAP2, consider, or I should say make sure that you demonstrate the impact of the involvement of your participants, that you communicate it and are clear about what has happened with the results of the day's discussion or the 6 months discussion, whatever the case may be. But the closing the loop is one of the places that we often see engagement work fall down, where you could do really great work and then charge off and do something with it. But if you don't circle back, you end up with Gail's 7-year silence for the referral. What did happen with that conversation that I had? If you do circle back and communicate and demonstrate the results of the discussion, then you will build again the virtuous cycle of willingness to participate, rather than simply, I went and I talked to them and I never heard anything back and I don't want to do that again. So there's a relatively simple formula for authenticity and community engagement. And what I really want to stress is that you don't have to build the crystal cathedral of community engagement for it to be authentic, or before you can get started. If you consider the inclusivity of your discussion, your process, if you're trying to be proactive, don't wait until you have a problem, a fire that needs to be put out. Start by pulling in interest before you even have really gotten going. If you're transparent and honest with yourselves and with your participants about where you're at, so we are just getting going, we've not done this before, we can't commit to you that we're going to turn over the keys. What we'd like to do is start by having a conversation about how we should engage. If you provide the appropriate support in learning for participants to engage meaningfully, and you've given some consideration to that value proposition, then what you're doing, I am sure will be authentic. It might be the beginnings, and it might be small to start, but KGH, Kingston General Hospital, is an example that is often held out as doing really good work, and they will be the first to tell you that it started with one person. It started with one conversation. It started with somebody who had a terrible experience in their facilities, and with a leader who was brave enough to say, come and talk to me about what happened, because I want to make sure that doesn't ever happen again, and I would love you to help me do that. And they now have an incredibly robust program that's embedded in all kinds of places throughout their organization. But it started with an honest, single conversation. And I don't think anyone will penalize you because they weren't the first one. If you are honest about how you started and where you started and how you grow the conversation, you will find willing participants to join in. So I'm almost out of time, and I want to just zip through this. The X-Files was the truth is out there, right? Well, this is, the help is out there. There are organizations across the world who have resource which is available online and freely offered. There are some things like IAP2 that have developed educational curriculum certification in patient. Presentation is available from our website. There's a bunch of video on our website that you can take a look at. These are all starting points, food for thought. As I say, there is no cookie cutter approach. There's no direct roadmap. You've got to sort of think through some of this for yourself, but this is great material to help you puzzle through it. And we are always happy to help guide to the extent that that we can, or direct you to resources. If you have questions or would like to talk about the specifics of your situation and how best you might get started, then I'm available to have a chat. So I'll leave it there. And right, the thing I hesitated to say before, so that people didn't get thinking about the Olympics, was that Canada won. 3-2 apparently. So one step on the way. Thank you all very much.
So welcome back.
My name is Rachel Stack. I'm the Quality Improvement Lead with the Southwest LHIN. And this next session is an opportunity for us to hear and learn from health service providers around how they are effectively engaging patients in their organizations, their programs, and their initiatives. This is only a sampling of the work that's really occurring locally and provincially around patient-client engagement. And so we know there are numerous examples out there, great examples of how health service providers, organizations are effectively engaging patients and clients. So we hope to just highlight some of those approaches today in our discussion and really think about, what is the purpose that we want to engage patients, and think about, is there a type of approach that we want to use based on that? So we asked the presenters to discuss the following questions. How has your program, project, organization engaged patients and clients? And what specific methods have you used? What have been the opportunities and challenges that you've experienced in engaging patients, clients effectively? And from your experience, what advice, guidance would you give to those that are just starting out in this journey? So there will be an opportunity to ask questions to the panel, to each of the groups, but we're going to allow the 3 groups to present first, and then we'll open it up for questions. So the first person I would like to introduce is Carmel Tate. Carmel Tate has had the privilege of working with individuals with disabilities and their families for over 35 years. The last 25 years at Participation House Support Services. During her time at Participation House, she has worked with an incredible team of staff members who are caring, compassionate, and have worked tirelessly to support individuals and their families to live in their community amongst family and friends. Carmel's educational background is in economics, business, negotiation and mediation, and numerous courses on quality assurance and value-based service provision. She has also worked on a number of local and provincial committees. So please welcome Carmel Tate.
Thank you. Mentioned to somebody else, I've just recently mastered the fax machine, so if I'm not very good with it, we'll see how it goes. Are we good there? Apparently I haven't mastered the microphone yet. Our mission statement, Participation House supports individuals with developmental disabilities and or complex physical needs to live in their own homes, participate in communities, and enjoy life with family and friends. To tell you just a little bit about us to get a perspective on the work that I'm going to talk about is we were established in 1988. We're a nonprofit, and we provide assistance to children and adults with significant physical and developmental disabilities. We provide 24-hour supportive housing in over 50 locations. Within those locations, we support individuals who are medically fragile, who require who are on long-term mechanical ventilation, other individuals who have acquired brain injury, children's services, and behavioral supports. They're in different homes, they're not all in one. We also have day programs where we provide center-based supports to families with adult children with complex care living in their home. We also have recreation, leisure, volunteer programs, and family resource. We've recently been funded by the LHINs to provide day respite and overnight respite to individuals with adults with complex needs, including technology and chronic mechanical ventilation. So that's a little bit about us. I'd like to, our operating principles, I'm not going to go through them all, but we wanted to identify that within our operating principles, we've identified the value of the participation of staff, but also that supported individuals affected by a decision must be involved in the decision-making process. So that is a piece of the principles of the organization. So that's the beginning or the base value of what we call consumer and family engagement. Now, what do we do to engage consumers? We have a biannual review. This is a larger project. It takes quite a bit of time. There's two pieces to it. The one piece is database compliance, documents, reports, rates, financial data, so we gather that. But the second part that relates more to the work that we're discussing here is participatory action research. In that, we engage individuals, families, community partners, and staff through one-on-one interviews, which our sense is that's always been the most effective. Visits to places, locations where people are, where people receive service, through surveys and through various focus groups. And again, the focus groups are small. They usually share. So the focus group would be with family members. Focus group would be with staff members. It's not that they don't get along. It's just that what's important to the family and what's important to the staff, although both very valuable, may not be the same thing. So it's easy. We have found it easier. Maybe I'm not sure I put that under lessons learned, but we have found it easier when we have people in a focus group who have a commonality. Now, what happens with the information that we gather is that it builds and provides information for our strategic directions. And by doing that, our strategic directions then has committees attached to it that carry out the work of the strategic directions. And on those committees would again be clients, family members, staff members, and community members. And by doing that, the higher level goals and direction of the agency for the next 2 years has involved the input of others, but also by having the action committees continue to work on the strategic direction. It moves the strategic direction forward, but it also ensures that the strategic direction is alive and fluid and continually getting input, because we found time and time again, although we have scathingly brilliant ideas, that 6 months later they really weren't that good, or something comes up where you go, what were we thinking? And, and that includes everybody. So that's one of the really positive pieces of it. The other part that's, I don't know if you call it informal, but these committees and gatherings create a shared knowledge and relationships, and that has been an important piece in terms of building a culture. Operationally, things that happen on an ongoing basis throughout the year, we have a quality assurance committee. That's a committee of the board of directors, but it is also again made up of clients, community members, and family members. We're also very conscious that it has members from the community or families from the community who are waiting for service, so that we are also engaging them and hearing about them and know what they need and want. They visit locations, they address issues regarding quality, and they again set time aside to meet with consumers and families on a bi-monthly basis. A lot of the work they do centers around what we call person-centered plan, which I'll refer to later. We also have an advocacy group that's made up of people we support. This group is working on and develops training videos for fellow consumers and staff members. They've also created a Walk a Mile in My Chair Day. This was an idea they came up with, is that they wanted staff to experience what it was like to be in a lift, what it was like to have somebody help you eat, and that how that was very different depending on just very subtle approaches, friendliness, the spirit in which the task was supported or the service received. And that was very, very important to them. That was something they really wanted to happen. Again, family and clients participate in new staff orientations. They share their perspective on what it's like to receive service, what it's like to have things done for you, to you, versus with you. And we have found that In all the evaluations we receive back from new staff regarding orientation, they have always addressed and marked this component very high. The staff really, really appreciate this. They really like it, and we get really positive feedback on that. The health and safety person, not so much positive feedback. We also have family and clients provide feedback on specific components regarding hiring and evaluation. The other component, person-centered planning, I mentioned that early. Each individual has a circle of family, friends, and people that gather together with a facilitator to make a plan about the supports and services and things they would like to do in the following year. And with that, we identify ways or barriers that may need to be overcome and identify who will take the responsibility or how we will support that person in overcoming their needs or barriers to make whatever they want to happen possible. So they create their dream, their vision, their goal. Our involvement is to talk about how we can be supportive or serve those dreams and goals. Another important piece is role modeling. It's very, very important for managers, supervisors, and board members to model and create a safe and accepting environment for feedback and constructive criticism and problem solving. You can do that every day, you can do it all the time, but if you really don't do it as the leaders within the organization, then you're not setting the tone that tells people it's okay to give us feedback. It's okay to say, I want to stay here, I like the people that work for me, but there's some things that need to change. And you really have to create that sense of safety. There's also informal communication, open door policies for consumers and family, shared events, informal events. And again, our sense is that as people can meet in a variety of environments, then the likelihood that the relationship and the engagement occurs and people feel comfortable sharing increases. Some of the benefits and impact. We feel that this process helps inform the directions and goal setting of the organization and creates meaning and value for those goals and for the strategic direction and also for the solutions that we come up with. Number two, creative, innovative, and effective solutions that work for everyone as all perspectives are taken into account. Our experience historically prior to this engaging families and consumers was that we often would come up with a solution that we thought solved the problem, that we hoped would be effective, but in many ways it made one group happy, but it created a larger problem somewhere else for two or three different groups. So by gathering people together to solve the problem together, you're less likely to come up with solutions that wreck somebody else's day that you didn't think about. So that's been very helpful. We've also been able to create an organization of inquiry, openness to change, and focus on finding solutions. Practically, just to mention some practical changes, it's helped with fundraising. It's been very clear when talking to families and people what they want to focus on. Our original PAR process identified transportation. Our most recent one has identified that people want assistance in being able to travel and take vacations, etc. So it does help with focusing or targeting your fundraising efforts. It's resulted in increased staff recognition, as that was an area that was identified that we could improve on. We've created augmentative communication teams and specialized training for staff in relation to technology, augmentative communication, etc., and that was at the direction of the people we support. We've developed a facilitator for person-centered planning. We've increased consumer access to Skype to provide better family communication, and a lot of family members, the parents may continue to live close at hand, but siblings have often gone far away, and to maintain that Connection is very important, and also very important as the parents are aging and want to build and maintain that connection. In a very practical way, and I think this comes into the value of lessons learned, we fixed a driveway, we've replaced a TV, we found a musical group for somebody. Those are important pieces, because if you're interviewing, if you're going to locations and there's something there you can fix, if you fix it, then people want to talk to you more and they want to listen. So, the lessons we've learned, the ones I just mentioned, if it's simple and you can fix it, do it now, because it reinforces the process and it encourages people to speak up and talk to you. Teach yourself and your leadership to listen, look to understand, and not defend and rationalize. You can ask why to solve a problem and overcome a barrier, not to explain its existence. So if I think of the sign you had about the wait that was 2 hours, I'm sure there was a rational reason for it. But if we get lost in that why, we don't think of why can't we fix it. And that's an important shift to move. We found to move, not explaining why it's there, figuring out how we can make it go away. If people don't have concerns or areas that need improvement, you need to work harder on creating a safe environment. You need to teach that constructive criticism is what the organization wants and needs to stay alive and vital. If your score is perfect, then that just can't happen, because we all know that the transportation isn't always arrive on time, that some staff didn't show up as scheduled and another staff doesn't like the schedule we have. So you need to feel that what you're doing and your engagement really is a reflection on the quality, and that people feel safe in doing it. And although one thing we found interesting was that the different stakeholders, people supported, families, staff, management, they often had different perspectives on what the problem was or how to solve the problem, but there was a very strong consistency and theme about the area of the problem. So use that, because that's the part that says there's different perspectives, but we do know that this is an area. I guess it goes back to that old where there's smoke, there's fire, but again, someone may think there's a problem in the morning because there's not enough staff. Someone else may feel there's a problem in the morning because the staff aren't trained enough, or someone thinks the buses aren't on time. But you do know you have a problem in the morning. And if you go and focus on that to solve that problem, rather than to have the conflict about solutions, you will get further ahead. And in closing, in conclusion, we have found that to be successful, quality and client engagement must be seen as an ongoing progression, where critical and constructive feedback is an opportunity and not a setback.
So thank you, Carmel. We had some conversations on the phone before today, and what I found was so interesting, we got into the concept of creating that culture for patient-client engagement, and you've done so many things within your organization to create that culture, and so it's really, really interesting to hear how you've done that. So thank you. So for the next presenters are Sue McCutcheon and Andrea Apeldoorn, and I'm just going to introduce Sue first. Sue McCutcheon is the lead for Access to Care initiative in the Southwest, and is passionate about ensuring that people, particularly seniors and adults with complex needs, have access to health care they need to stay at home as long as possible. As a self-described lifelong learner, Sue has achieved a master's in nursing and a master's in health administration. Sue began her career as a registered nurse at Victoria Hospital in London, eventually transitioning into management and executive positions that have provided her with an opportunity to make a difference in the lives of patients by teaching nursing at Fanshawe College, London, being a director of care and administrator in long-term care at Summit Place in Owen Sound, and most recently a vice president at Grey Bruce Health Services, managing clinical services in 5 rural hospitals, 1 larger community hospital in Grey and Bruce counties. Well respected among her peers, Sue has contributed to multiple Southwest LHIN committees and has remained committed to the work of the Southwest LHIN Quality Advisory Group. Andrea Abeldoorn is the Access to Care Communications Lead with more than 10 years of fund development experience at Lambton College and St. Joseph's Hospice in Sarnia. Andrea has successfully used client experiences over the years to demonstrate for donors and volunteers how their contributions make a difference in the lives of people their contributions support. So please join me in welcoming Sue and Andrea.
Thanks so much, Rachel, and it's a real pleasure to be here this morning. And we need a new script writer. That's way too long for an introduction, because we really are here to talk not about us, but about the people that we have the opportunity to work with through this particular project. And so I'll just start by talking just a little bit about Access to Care. It's a little bit of an oddity in the province. Access to Care is a project. We're in year 3 of it, and it's really been set up to support those seniors and adults with complex needs to stay in the community as long as possible. It is predominantly funded by the LHIN and some of the other health service providers, and Andrea and I have the privilege of being staff members with the CCAC, who is a key lead in this particular work. And so the work that we've done to really try and support seniors and adults with complex needs in the community is around supporting, strengthening the community and all of the different supports, similar to what Carmel was just talking about in assisted living. We've also talked about improving, not so much improving, but expanding the home care capabilities in our LHIN. Talking with hospitals about how they can change and support seniors better, as well as accessing specialized services. And so that could be something like complex continuing care in a hospital. It could be rehabilitation in a hospital. It could also be very specialized services like Carmel was just talking about, supporting a person who had actually ventilator needs in the community. So lots of tentacles to our work, which means lots of opportunity to talk to people about how we can do things better. So as I said, we're about 3 years into this project, and I would say when we started, we were really neophyte, and so Andrew's comments earlier this morning resonated for me because I would say we didn't have a clue necessarily when we started, except the only thing that we knew was that the patient story was important to us. We didn't really know a whole lot more than that. We started out actually collecting patient stories and honestly not really knowing what to do with them. We used them for marketing to help describe our work. But then early on in the project had an opportunity to chat with a qualitative researcher who said, well, you've got these stories, maybe you should be doing something with them. And so it was Carol McWilliam from the University of Western Ontario who really helped us think about how we could take not only those patient stories, but more patient stories that we were able to talk, more patients that we were able to talk to, and about how to really develop that. And then about 6 months after that, we had the opportunity through the LHIN to actually participate in an experience-based design workshop, and really so that pushed us a little bit further. So I would say we're still evolving this, and so it's not something that I would say we're great at, but we're working hard to get better at. And so we focused in on 2 pieces today. One is the qualitative evaluation work and the experience-based design work, and really making sure that we can capture the stories and understand all the different touch points. I would say that many people told us very positive stories, but if you listen, and I call it listening between the lines, if you really listen, there are all sorts of points during that story. The outcome might have been great in the end, but there were things all along the way that we could have done a whole lot different to make that journey much different from a patient experience point of view. And then, of course, to redesign the experiences, and I'll touch on this a little later too, but honestly, we are neophyte in the redesigning the experiences with the patients. We've done a lot of validation, consultation, advisement, and we're just, had a couple of good success stories, not just recently, but it feels like we're pretty neophyte in this. And you saw this slide earlier this morning. This is really about capturing, understanding, improving, and co-designing, and then measuring. And the only comment that I would have that's maybe different that other people haven't said is that measuring for me, and in this work has been a big value to us, is that measuring is not just about the nice graphs, and we've got lots of those. It's also about what difference has it made? What impact have we made? And what impact not only have we made, but we together made? So it's not just, as I say, not just about us. It's also about the person. I'm going to turn it over to Andrea, and I just want to say a little bit about Andrea. You heard her bio, but I talk about us pooling our resources. You heard I'm a nurse. I come to every situation with that kind of framework in my mind. Andrea comes from a communications background, and she listens differently than I listen. And so as a pooling of resources, we've really utilized Andrea's experiences and understanding of communication to help us actually capture those stories. So over to you, Andrea.
So I have to say, I'm going to focus today on the interviews that we have used to really become involved in experience-based design. And I have to tell you, going into a client's home and actually doing an interview, sitting down with them and getting them to tell us their story is just an incredible privilege, and I really feel honored that they share this with us. There we go. When we do our interviews, we actually go in with pretty much every interview, and we kind of focus on these set questions. So, we start out with a little bit of small talk, which obviously puts everybody at ease. And then we kind of get into, tell me about yourself and how this situation has come to be. And the responses to that can go all the way back to, well, in 1948, I left Greece, and my father was sick the day I left. But it really goes to show that people have just such a broad experience base to draw from, and they just have so much to give. We also talk about, what helps you to live your life to the best that it can possibly be, what obstacles are most challenging to you, and what supports you. Like, if you could have anything in the world to support you here, what would it be? And this is always a scary question, we find, because what if somebody says, well, I want 24-hour care every day, and I want to remain in my home until the day that I die? One comment that we received from a woman was, I'm not leaving here unless it's in a pine box. Which, it's a scary question to ask, but rarely do people actually tell us that they want something that we can't provide. Most of the time, the answer that I get to this question is, oh, nothing. I'm getting so much already. So it's a really incredible question to ask. And then we always end with, so what is the most important message you want me to take back today? So these interview questions have been really, really effective for us, and this is, Sue referred to the qualitative review. We received these questions from Dr. McWilliam, so they've been really, really effective. Now, as you go through interviews and you start your first interview, the questions seem pretty stilted, so that just do it piece, you have to do a couple of interviews that do feel stilted. And then once you kind of go through the process, you're able to review the interviews, and it's always good to review the interviews. We actually audio record our interviews. If at all possible, we love to video record, although people are reticent to go on video recording. We always take pictures, if the client and the patient allows us to do that. And then we always transcribe the interviews or listen to the interviews, read the interviews by multiple people, so that we've got multiple sets of eyes and ears listening for the nuances and reading the nuances. So that's really important to us. And then from there, we actually will pull out themes. Now, I'm just going to give you a couple of the themes, because so often if you walk into somebody's home and you say, oh, how was your experience? And they will say, oh, it was fine, dear. It was lovely. But then once you get into your interview process, that's when you find out that every story that you hear has really positive pieces to it and really negative pieces to it. And there's so many opportunities for improvement throughout every story. But again, the answer that you asked, how was your experience? It was fine. So this is two of the themes that we've pulled out. So being at home improved my outlook for the future. One woman actually said to us, my plans were to die unless, so that I would lose all of my worries about what was going to happen to me in the future. And we really try to use their direct quotes to really talk about what is going on in their lives so that we can focus in on the solutions that they're telling us. I have the chance to make my own choices, so patients really want to be involved in not only their care, but in the work that you're doing here today. Just incredible. And you'll see we do use pictures in all of our presentations. So just wanted to touch on what co-design looks like. So we go out, we do these interviews, and then how do we use those interviews? This is a really great example. So in working with assisted living, supportive housing, and adult day programs, specifically with regards to special populations, what the co-leads for this project did was they went out, they did all of these interviews, and in this particular case, it wasn't with clients themselves, but it was with their families. And the families provided all sorts of feedback on what they needed. The report was written, the recommendations were developed, and then the co-leads of the project actually went back to those same people and said, here are our recommendations, what do you think? And again, those people were able to say, okay, that works for us, that works for us. This needs to be changed a little bit. So in developing these recommendations, it was a perfect opportunity to really involve clients and their families into the recommendations. The final report was submitted, and it is accessible online on the LHIN website. And those recommendations have the endorsement of the people who are actually going to be using the services with their loved ones. So that's a really important piece. One of the questions that we that Rachel posed to us in preparing for this is what opportunities present themselves with this work. And one area that I would definitely say this work has provided us with a real chance to, when we're communicating about the work that we do, to provide balanced perspective. This particular slide is one that we use, and it actually talks about e-health technology. And it's not always the most exciting conversation to have with people, although the outcomes are really exciting. So it was just an incredible chance for us to take the client stories that we had and start to explain facets of our project with a client perspective. So this is how e-health technology will change, and this is Norm, this is how it will change Norm's life. And so that has been really great for us because it gives us that opportunity to enable audiences to make their decisions with part client or patient perspective and then part system perspective. So that's been a really great opportunity that has come out of this that we didn't necessarily see coming. And with that, Sue will kind of talk to you about our key learnings.
Thanks, Andrea. So this is the last question that Rachel posed was, what did you learn and what might you advise others to do? And the first one is just, it does improve the results. I can't imagine actually having gone through the work of this project in the last while without having that voice, being part of what we're doing. I don't think we would have had any idea if we'd hit the mark or not. And I wouldn't say that we have totally hit the mark, but they're helping us understand where we're heading. The other thing is I think when we started, we thought, well, I'm not sure that patients or clients even want to talk to us about this. It's a big system project, and it's not maybe, down practical about when when fixing signs or doctor's office appointments and things, will they, but all we had to do was ask. And we've had lots of people who have come forward. We talk about numbers aren't important, and they aren't to us, but we do ask, and people do say, yeah, we'd love to tell you our story. And outside of getting videotaped, even the agreement to audio tape so that we can use that story to continue to improve the system has been, I don't think we've had one refusal to have it audio taped, and we've done lots. So just ask is the advice. And I think we often got caught up in the idea that it takes a lot of time and resources to do this. It takes the client's time or the patient's time, it takes staff time. What are we going to do with it? How do we really honor it? And I would say that over time, that gets easier and easier. And right now, we don't even think about it. It is part of our work. And so it's easy to get over that hump. Just go out and do it, and it will happen. Andrea, I listened to all of the interviews, it's been really fun to watch Andrea's skills. She was good in communication to start with, but her skills in talking with patients and clients and really interviewing over the last 2 years has just skyrocketed. And so don't worry about being a little bit naive or not totally skilled when you start. You'll learn and get there. And I think the more you, I think somebody else said this earlier, the more you talk to people, the more opportunities that come around that people are interested in talking to you. This point about being both positive and negative, I think, Kathy, you touched on that this morning. We can have those stories that overall, you know, in the last whatever, have been a very positive experience with the healthcare system. But if you listen, there are definitely times where we could learn. And I think of one gentleman who we interviewed recently, and his story was very positive. He's been home, he's been well supported at home, he's back with his family. It's really been a positive thing for him. But he said, you know, I had to go to the hospital. I had this acute episode, and I needed to go, and it was kind of urgent, and I had to call the ambulance, but the ambulance people didn't know him and didn't know the very specific needs that he had that had been taught to his caregivers in the community and his family members. And so, although his experience was very, very positive, we need to do some work to help support EMS in their care in that particular community. And I think for me, the other piece was it's really important that we hear. And I said earlier that I worry about me coming in with a nurse's hat on and you know, thinking about solutions that may or may not be the solutions that are right for the patient and client. And so it's really important to sort of take that hat off and say, what is important to you, and not always concentrate on what works best for the healthcare system or what works best from a provider view. And the Just Do It piece, I know that that's a pretty canned slogan, but for us it's been about just get out and do it, and you'll figure it out as you go. And that's worked, I think, really, really well for us. And we've had lots of support from the LHIN to be able to talk about these stories, but whether we've been able to talk about them in the broader sense, we've been able to use them day to day in our own work. And one of the ways that we've helped, I think, shift how people think about patient experience is about taking providers in particular to where they are. So what is it that you're doing with patients? What are you talking about with patients? And starting there, because inevitably every provider will be doing something, and it's about starting where they are and helping them move along the path with us around patient experience. So with that, I'll pass that back to Rachel. Thank you.
So thank you, Sue and Andrea. That was great to hear about the practical application of EBD and describing how you've used these patient stories in multiple ways. And one thing I do want to mention is that if you are interested in experience-based design, the Southwest LHIN website actually has some more information about experience-based design. So we can send you that link after today's event. And even the group may be willing to share some of their presentation so that you can get some of those really good questions that they had when they were doing the interview. So thank you, Sue and Andrea. Okay, so our next presentation is from Jordan Weber and Anne-Marie Underhill. So Jordan Weber is the long-term care home representative on the South Georgian Bay HealthLinks Change Team. He currently works for the County of Simcoe at Sunset Manor as the Quality and Development Coordinator and supports the home develop and maintain quality improvement initiatives such as Montessori programming and falls prevention programs. Jordan's background is in community-based recreation programming. He is the graduate of the University of Ottawa's Masters of Health Administration program, which included an academic residency at the Perle and Rideau Veterans Health Center, where he did analysis of X-ray services for long-term care homes. And Anne-Marie Underhill is the coordinator at the South Georgian Bay Community Health Link. Drawing on her administrative and project management business background, she has worked to ensure the HealthLink initiatives get off the ground. Anne-Marie has had several years of experience as a personal support worker. She has worked with the Red Cross Supportive Housing Group and then moved on to run a successful senior care business in Collingwood. She brings with her well-rounded experience to the HealthLink team in the South Georgian Bay. So please welcome Anne-Marie and Jordan.
Hello, everyone. So we're here from the South Georgian Bay HealthLink, and just want to give you a little bit of a background on how we are set up to run our HealthLink, because I think it will be different in many cases as the business plans seem different all over. We're just at the beginning stages as well of our patient engagement. We have 7 pilot patients underway with our coordination. So to start, we have an executive for the South Georgian Bay HealthLink, which consists of 2 physicians, the rep from the CCAC, the CEO from the Collingwood General Marine Hospital, the administrator from the long-term care in Simcoe County, 211 Community Connection, representation from the LHIN, our Georgian Bay FIT, and the CHC. So that comprises the executive. And each of those executives have chosen members of their organization to sit on our change team. So as you can see, we're looking for a group of people, and again, this is working towards breaking down some silos and having everybody work together. So part of the change team has been a commitment from their organization. Part of their performance measurement in their organization is the successful HealthLink initiative. So that's written right into their job description, basically. So that gets buy-in, I think, from everyone at the table. Just looking at the change team, the people that are on the change team, you can see it's a lot of who I mentioned in the executive. I'll just highlight a few of the other ones that I think are important to have as we've drawn on their support. Home for Life in our area is a volunteer organization that started about a year ago. They have about 180 volunteers, and they have approximately 376, I think, seniors that they're going out into the homes and helping in various ways. So we have the manager there on our change team. Also, a seniors residence. This is a brand new person that's joined the team, so we're hoping that the change team will grow as well, and it has seemed to. So Chartwell in Collingwood, she came on board, and she is very happy to be there because she's learning how things work in the community. And so we have as well, we have our LHIN QI specialist, that some of the things that we come up in our change team meetings that she can bring forward for us. We also have HQO with our quality coach to help guide us along as well. Just recently, we brought on a mental health lead, which is important because when we talk about where we're going with our change team and how we're initiating our HealthLink, we haven't chosen a specific diagnosis, but we are looking at, don't like to use the term, but a high user of the last one down there you'll see, but an important one is the patient champion. So we have had an opportunity to have a patient sit in on some of our change team meetings, but we do know that that is hard to do, and obviously when we're meeting on a weekly basis, it's not easy to get somebody there every week. But we've recently written a job description that we are going out into the community and looking for somebody that will be our champion. we're hoping that that person will go out into the community, speak at some of the programs that we're going to on the radio, and when we're talking to any of the organizations, to have them come along and have them be very well versed in what we are trying to do with our HealthLink. So I'm going to talk to you a little bit about the patient engagement as it deals with the collaborative care and the model that we're using. Jordan is going to speak to the community engagement with the patients. So we'll kind of split things up a little bit here. So I'm just going to sort of walk you through what we're doing so far. And as everybody's talked about, we've, plan, do, study, act, we've jumped in. We weren't quite ready, and we've been learning along the way, and we continually review things. So as I said, we're only underway with 7 patients, so we have learned a lot, but we know we're just going to keep learning more as we move forward. So far, our identification of the patients has come from the physician that is on our change team. So because he understands what we're trying to accomplish in HealthLink, he has made the initial contact and got a consent signed by the patient for us to come in to do an interview and to have them work with HealthLink. That consent form, just for people that are starting out, it was an important piece. We have to make sure that they understand that their information will be shared and how it will be shared and how they are protected. And so we have a privacy officer that's been hired, and they're working through every bit of the process with us. So it's important, and we're happy to share that consent form with others who are kind of getting underway as well, and they may want to use that. So that's done right now with the physician. That's changing along the way, and I can touch on that later. But we do the same thing as we were talking about, and we go in the home, we do an interview, and we consider it a discovery interview. We're really trying to get the same as everybody else, their patient story and their goals. And it is a little bit scary to hear what their goals are, because as the health professional sits there and says, that's not going to happen, that can't manage that. We have found, as we've moved through these 7 patients, that we have the main goal, but as we move through, we can do some short-term goals to try reaching that, and that helps align the goals. And so I think, as you said, don't be afraid of hearing those big goals, and let them come out and let them say everything they want, and we're feeling the same way in our interviews. We take that information that we get from that patient interview, and we go back to the change team originally, and we draw on all the information from our leaders on the change team and community services in there, and look for ways that we can think outside the box, or whether somebody's had an experience with a similar situation, whether it is transportation, it could be any of the things that come up in a care model. But we go and we get the information from the change team. We found that wasn't enough, and we needed people that were actually in the field, and people like PSWs and social workers and OTs to be in our think tank. So this is a brand new thing we've just created in the last few weeks, and is actually a conference call that happens weekly. So when we are going out to do an interview with a patient, we are coming back and going to the think tank when we need to, and drawing on their expertise for some ideas. So that's something that's worked well for the initial client, and then we have another call tomorrow that we'll have a few more. So that's very new and underway. From that think tank, we go back to the patient and try and create a care plan with them, with their input, and actually with their approval, because we may have all these great ideas and want to bring all these services in, and we get it all ready, and they're like, well, I don't want that. So we do know that there's a touch base before that care conference to say, here's what we have in mind, how do you feel about it? And it has to happen, and we've really taken note of that as well. Another big thing we've come across, and I will touch on later, is the scheduled weekly updates. We found that as we start the program or we initiate more services into a home, if we leave them for weeks without touching base with them, by the time we do, they're so full of anxiety, and they may have problems and they're upset that everything is negative that comes out. When we offer to have a weekly call on Tuesday at 10, then they jot down what they need to and they share it with us. So that's something that we'll talk about a little bit more, but that works very well too, and that constant communication between them. And it takes away a lot of anxiety, we learned. And the regular patient satisfaction survey. So that's us going back in and just asking them how they're doing. This is our patient-centered care model right now. You can see all the people that I've already talked about around the circle there. And 211 coordinator, I'm just going to touch on that, and how we're using the 211 service is that we're finding overlaps, we're finding areas where they have done deeper dives into the system and they know wait times and wait lists. It might take away from some of the social workers' workload. So that's something we're addressing, and certainly when we have questions, we can always get, they are doing the investigation for us, so they have a lot of the information right on the tip of their finger there. So the lessons learned that, that we would walk through is, as I mentioned, the proactive weekly calls. The small changes can go a long way. So we're sitting in a house, we're talking to a caregiver, we're talking to a patient, and we're trying to understand what's wrong with the situation, how can we change it. And sometimes it is a really small tweak or an education component, but you know, it might be looking at they had 21 hours of PSW service, but they were coming at different times and it wasn't really working. So the simple fix was to take that afternoon visit when there was usually someone in the home from their family and combine it into blocks of time and give that husband his respite and get out of the house and be able to. And that was a simple fix, working with CCAC and modifying one of their schedules. So little changes, but went a long way, took away a lot of the anxiety of that patient and their family. We're finding the use of the volunteer invaluable. We have used them in every situation because they can fill a small role, help reach a goal. One of the goals was I would like to bake again. I would like to play piano, and we have a whole 180 volunteers to go to and find somebody that has a great fit with them. So that's something that we've drawn on for all of our health and patients to date. We also know that going back to them with a care conference is not always the right thing to do. There's been a situation where there was a mental health condition where they would have been completely overwhelmed having that many people in a home and going back in there. There's also been situations where it just wasn't necessary. As I mentioned, it was just adding an education component about diabetes or changing or having somebody come in and speak to them about diet and change and that type of thing. But what we are learning is everything we're doing, we have to think about the sustainability. And, you know, we all go out there charging out there with some great ideas, but how are we going to sustain this? And how is this really going to work? I can't possibly go out and do all the interviews in the South Georgian Bay area. So one of the areas is the interview training. And so we've just recently completed training, and I might draw on you to get some more feedback from you out there. But we've had somebody trained, a social worker trained at our Georgian Bay Family Health team, at the CHC and at our CCAC, their care coordinators. So we've gone through that training and written a process so they understand what we're looking for in that discovery interview. We haven't yet recorded, and we've talked about recording the interviews, and I like the idea, and I will have some questions about permission granting. And that's the same thing we're talking about. You know, you want to do it, but you put all these blocks up. We couldn't possibly do that. That can't happen because that would be a violation. You know, we're always caring about the privacy issue. So I would be very interested to learn that because I think it would be very useful. The improved technology I want to touch on. We just had a demonstration yesterday, an IT demonstration, where we are working with the EMR, and we are creating a patient portal where we can message. And right off the bat, that's going to help us set up these interviews, be able to draw on to the physicians and be able to say, we're going to the house to do the interview then. If somebody's in the home and CCAC wants to message the provider, the care provider, whether it's a physician, they're able to do that through the EMR. And we're working to put all of our agencies on the same system. And it's a big deal for us. And having the first demo yesterday was positive, and I think it will be in March that we may be able to go live with a small portion of it. So that's very interesting. What I think is ongoing is the navigation piece. Understanding, and we find this in the interviews, of how do they get through the system? Are they looking for somebody to do it for them? Do they want to do it themselves? Is it several people in the system that need to do that? And we are actually having Project Stream, and one particular one that's working on that navigation piece because we're trying to understand what it is for HealthLink and how it will work. So that's going to be an ongoing piece that we're going to try to identify as we move forward. So one of the things that I talked about, I don't know if I mentioned on there, was there was a lot of stress we found. We didn't realize this. Before we went into the interview and after we went back to them and said, how did everything go? They said, we were so worried about this interview, we didn't know what it was. And we had no idea because they were just sitting ready in the kitchen and had tea on, and we didn't realize it was stressful. We didn't know that. So we've come up with a way to give them a piece of paper, and it almost looks like that, pretty well like that. And so this is just for you to think about. We're going to be here in a few days, and these are the kind of things that we're going to go through and we're going to talk about. Don't write anything down, you know, we just need to think about these areas, and this is basically our discovery and what we're looking to ask them. We also just yesterday wrote a letter which can be given to a client that we want to bring on to HealthLink, and Jordan is actually going to run it through the patients and find out how they would read it and how they would understand it. So that's how we're engaging with patients in the care model component. And then I'm going to have Jordan just speak a little bit about how we're working with them with the community engagement. Okay.
So now you kind of understand how we're involving patients with their own care. This is sort of how we're involving patients with the system planning point of view. So I came on board as part of the change team that Anne-Marie referred to in September. So I'll share with you some of the experiences we've had engaging patients since then. Since our first meeting in September, we knew patient engagement was a key priority. It's just a matter of how we're going to do it. We debated the idea of having a regular patient attend or a number of patients attend on the change team, but we didn't totally understand what that looked like. We decided to have a regular attendee would be a burden on that person, possibly could be misrepresenting if they're only familiar with their own experiences. We decided instead to have a patient advisory council or patient advisory group. This would be a group that we could run ideas by or help us identify the issues, and it could be a representation of a wider range of patients that we could then consult with as a change team. So we started out in September, but unfortunately it took almost 2 months to get this first group together. It was a lot harder than we thought. It was almost like pulling teeth trying to get people that were interested, had the right level of experience, and the time available to contribute. So it took all of everyone on the change team, a lot of recruiting, and a lot of organizing and planning to work around everyone's schedule, keeping in mind we're trying to get people that are caregivers or have their own healthcare needs to take care of first, and so organizing that around everyone's needs was difficult. We did have some valuable comments, so I'll let you read them as they come up here. It was definitely a worthwhile process that we went through, and these are some of the comments that we took away from the meeting. We have referred back to them on our weekly meetings ever since, so we certainly had some very valuable lessons. We went through and had everyone tell their story, which was probably the most valuable part of the meeting. There was only one of 4 things on the agenda for that meeting, but ended up taking the majority of the time, just because everyone had that rich story to tell, and it's so valuable to hear the story in its full detail. And at the time we imagined this group maybe meeting again and again. We thought the sense of bonding would be important. Everyone could understand where each other's coming from, and also we'd know each other's experiences, so we could be able to draw on that experience, and they'd be the expert in that certain area. Unfortunately, the group wasn't overall able or interested in meeting on a regular basis. So that idea, although the meeting was very valuable in its own sense, it wasn't an ongoing thing. We weren't able to continue to do it just because of the group of patients that were around the table being interested and involved. Some learning moments we had that will definitely carry through to some other things that we've been doing, and some things that we learned that worked well and we do again from the Patient Advisory Council is allowing everyone to tell their story. Letting everyone give, I think we scheduled about 10-15 minutes for everyone to share their experience with the healthcare system, but obviously that took a bit longer because some people had more details to share. Some people started off with where they were born and went from there, and some people just said what happened yesterday and that was it. Everyone had their own comfort level with sharing, but allow for that openness to happen was very important. Different level of expertise. Some people in that group were very familiar with the healthcare system, Some people help write grants for other people to apply for funding. Some other people were already involved with some LIN initiatives and involved with as patient representatives in other groups, whereas others just familiar with their own care but had equally valuable experience to share. So we'd allow that conversation to be generic enough that everyone could contribute. Some of the feedback that we got was that allowing everyone to be prepared for the meeting, we had sort of given an overview of what we'd talk about, but I think overall people want a better sense of how they could prepare for that meeting, what the subjects would be. So we found that in a couple of the initiatives that we've done is that sense of wanting to know exactly what we're going to talk about. We tried to work that into future things. And finally, overestimating the number of people that we need. And we found this in the next couple of things I'll share with you as well. We had 15 people scheduled to show up to the meeting. 9 were able to come, so it still worked out for a great meeting. However, there was that part of the meeting that couldn't come due to their own needs or needs of people they were caring for, whatever reasons that day they weren't able to attend. So that was kind of phase 1. So as a change team, we continued to meet, we continued to work on the collaborative care model, and things were coming up that we sort of needed a more standardized quality improvement methodology to sort of focus our efforts on. So we decided to have a value stream mapping day. This was effective, and obviously we wanted the patient, client, consumer side of things as well. So we had all in one day. It was led by a Health Quality Ontario lead. We had frontline workers from social work, mental health workers, nurses, nurse practitioners attending as well as several physicians. 1 patient participated, even though we had 5 originally lined up that were interested in attending. 2 were definite, and then due to the weather that day, only 1 was able to attend. But we were able to get some valuable project streams that we're currently working on now out of that day. Similar to the Patient Advisory Council, there's some similar lessons learned. First of all, being flexible and accommodating. Some of the people that were originally lined up, we had to make help them make changes to their care needs, arranging transportation, as I think we talked about, making sure that their care could be changed rather than having that in the morning, having it at the end of the day, and anticipating that they had high needs to be able to work around to attend that day. Also, we invited people to attend the full day, and then just from some initial feedback, we realized that a half day would be more realistic. So being able to say, okay, well, whatever you can make would be much appreciated, and maybe it's not realistic to expect someone to attend for the full day, but a half day event is more realistic. So being flexible and accommodating. Secondly, discussing everything in plain language. The patient representative that we did have was a great advocate for himself and saying, I don't understand that, can you please break down that acronym, even though we're trying our best to keep things simple and straightforward as possible. The feedback from that one patient was also to give him a bit more preparation in advance. Even though he had the agenda and what the value stream mapping was hoping to achieve, he was still looking for that extra, what could he bring ahead of time? Not that we were expecting him to prepare a whole lot, but having a better sense of what the day would be about was important to him. And again, like I mentioned, overestimating the number of people that we needed was important. Maybe we would have extended the offer to 10 or 12 patients next time, expecting not everyone would be able to attend. So that kind of takes us up to current day, an initiative that we started last week. Realizing what we've taken away from the last couple events and also the initiatives that we're working on that Anne-Marie spoke to, we still need to get a more timely source of patient-client feedback. And how can we quickly run an idea or ask about a certain idea that we have to a big enough group of patients in a short period of time? So we developed the idea of having an inventory of anyone interested with healthcare experience to sign up and be sort of available on short notice to give their feedback on initiatives that we're working on. So we started by sending out a form to people. I'll share with you in a minute. But so anyone with any kind of interest could contribute and send in this form. And this is what it looks like. Not expecting you to read it word for word, but the top third of it here sort of gives a brief description of what the HealthLink is about and our goals, along with some of the organizations involved to give them a sense of the scope of the HealthLink. The middle third of it is just sort of basic contact information. If you're interested, name, phone number, email address. And then the bottom section is what level of engagement are you willing to or interested in engaging in, whether it's a brief phone call, whether it's a phone interview, in-person interview, focus group, or full-day value stream mapping type event, sort of to gauge that level of interest so we can quickly get a group together for a focus group within maybe 2 weeks rather than 2 months, or quickly have some interviews with people over the next week or two, or do an online survey over the next day or two to get that quicker level of engagement. So distribution of this has been going out throughout the South Georgian Bay area, and starting with the change team and everyone involved, really drawing upon their own organizations and realizing that if you just stack these forms in the doctor's office, not everyone's going to stop and pick one up and see what it's all about. We're hoping to draw on relationships that already exist with care providers, with group sessions, whether it's sort of an addiction group session or exercise group session. Maybe the facilitator of that session can pass out these forms and say, are you interested in this? Fill it out if you are, and sort of build on those relationships that we know already exist. There's some other creative ways we're sending it out. The South Georgian Bay Family Health Team has created an initiative for staff to see how many they can get back within the next month. The VON Adult Day Program is sending out with caregivers in their monthly newsletter. So really just trying to send this out as broadly as possible and get back as many as we can. So in the end result will be a long list of names, hopefully, that we can draw upon at a shorter notice and get some more timely patient engagement. Just sending this out, there's been a few hurdles along the way, but nothing we haven't been able to overcome. First, description of the HealthLink. How much do you explain of the HealthLink? What exactly is it? What does it mean to that person? And it's different to everyone. So keeping it high level and generic enough was important. Targeting the right people. HealthLinks is designed at initially targeting sort of the high user group of the health system, but how do you target that group when you're getting feedback? We decided that it's important to get anyone with experience and just send it out there on the masses just to get any experience is better than no experience. And then also the limited information. We're not asking for everyone's full health detail on that form. It's just a matter of, are you interested in participating? And then maybe if we're having a focus group, we'll call in people with certain experience and screen people based on their experience as we need them. So in conclusion, the next steps is just about sustaining these things that we've spoken to, sustaining the patient and client engagement in their care, as well as that culture change. Now we have this long list of people who are willing to participate, but it's about using that list and following up with those people and getting that part of our conversation. If we have a new idea, almost being a broken record and saying, how are we engaging patients? What would they think of this? When are we going to send it out to them? And that's sort of where we're at now with sustaining and keeping this going. Thank you.